Okay, good morning. What?
You like the little breaks, the 15 minutes?
No, I usually don't. I usually try to keep it for 10. But sometimes it doesn't always work out. Oh,
Oh, you okay? Yeah. I like that skirt.
thank you.
Okay, so many compliments today. Okay.
Much material to get through. So much. Any questions before we get started? We definitely need to get started. Oh, are you?
Is it true that you can take the influx at home now?
I don't think they approved it. I don't understand how it's ever going to be. Yeah.
So you
It doesn't make any sense.
like for my son for his college class, he had to download a specific app. It's like the lock screen app.
Yeah.
But yeah, so he can't look away from his computer screen. There can be no sound in the background. His mic and camera have to stay on the whole entire time. It's like a whole thing. And he's like, Mom, I said, you're fine. And then they were like, he had to show his ID. He said, I'm 12. I don't have an ID. I said, you're 12. They're going to know it's you on the camera. Like, they won't mistake you with any of the college kids, I promise.
Okay, so we left off at tetracyclines. Tetracyclines start on page 124 in our book. So all of these meds end in cycline. Okay. Everybody can hear me okay?
Yes,
Yes,
ma'am.
All right. So, all of our tetracyclines.
Miss Simmons,
Okay. Your most common, yes.
can you share the screen?
Oh, sorry. Yes. My bad.
You were just testing if they were going to speak up, huh? That's what it was.
Oh, that's silly. Okay, better? All right. So your most common tetracyclines is definitely doxycycline. Okay. If you have ever taken doxycycline, you would know that it tears your stomach up so bad. Nausea, vomiting, diarrhea. Guess what? You're not supposed to take this with food. It actually changes the way that the drug is absorbed if you take doxycycline with food. Okay? Which is really hard when it causes you to vomit. Okay? So, where does it say it? Tetracyclines are absorbed adequately, but not completely from the GI tract. Their absorption is affected by food, iron, calcium, and other drugs in the stomach. It's concentrated in the liver, excreted unchanged in the urine. It's bacteriostatic. So what's the difference between bactericidal and bacteriostatic?
You don't want to Static blocks.
Inhibits
Yeah. And
and
the other one
bactericidal
kills.
kills. Yes. So it inhibits the protein synthesis in a wide range of bacteria, leading to the inability to them for them to reproduce. Okay. These are toxic to humans in high concentrations, which is kind of scary. Okay. And is indicated when infections that can usually be covered with penicillins is contraindicated, like if they have a penicillin allergy. Okay. So again, I was just saying that they are absorbed from the GI tract. They're concentrated in the liver, excreted in the urine. So that means they're both hepatotoxic and nephrotoxic. Okay. A very, very important contraindication. It says tetracyclines are contraindicated in patients with known allergy, obviously, during pregnancy and lactation because of the effects on developing bones and teeth. Tetracyclines should be used with caution in children younger than 8 years of age because they can potentially damage developing bones and teeth. You ever see a kid with gray teeth?
Yes.
No? Google tetracycline in children's teeth. It destroys their teeth and the development of it. So you should never use these drugs in children that are less than 8 years old.
Is that only baby teeth, or does it go deeper into the adult teeth as well?
I believe it goes deeper to the adult teeth.
I figured.
So, yeah, it's absolutely terrible. And you have to think about how many kids screwed their teeth up before they figured this out.
Yeah.
Right? So your adverse effects include GI, which include nausea, vomiting, diarrhea, abdominal pain, glossitis, inflammation of the tongue, and dysphagia, difficulty swallowing. That makes me uncomfortable. Fatal hepatotoxicity related to the drug's irritating effect on the liver has been reported. Skeletal effects involve damage to the teeth and bones. Because tetracyclines have an affinity for teeth and bones, they accumulate there, weakening the structure and causing staining and pitting of the teeth and bones.
And does it goes to the pregnancy, not to the baby?
So it affects all of their
That's what
teeth.
I figured.
Yeah.
And you said fatal hepatotoxicity?
Fatal hepatotoxicity. Hematologic effects are less frequent, such as hemolytic anemia. When we talk about hemolytic hemolysis, that's the destruction of red blood cells. So the person is anemic as their red blood cells are being destructed. So it's rare, but it can happen where you see anemia with tetracyclines caused by the destruction of the red blood cells.
Page are you on? Sorry.
125. And then under clinically important drug-food interactions, because oral tetracyclines are not absorbed effectively if taken with food or dairy products, they should be administered on an empty stomach with water 1 hour before or 2 to 3 hours after any meal or other medication. However, if gastric distress occurs, clients may take with small amounts of food even though this decreases absorption. This sounds extremely important to educate your patients on, correct? Yes. So I would say it's something that you would need to know.
So you would rather than just have less absorption of like throwing blood. Basically.
What?
You would rather them have a little bit that's gonna like
A tiny bit.
tiny bit.
But it also says that iron and calcium affect the absorption. So Would you want them to take this with milk?
No,
No.
it just sits.
Would you want them to take this with a high, like a steak, where you have high amounts of iron, or an iron supplement? No. Any type of, this reminds me, make this a rule forever and ever and ever, because I'm telling you, I'm sure that there's something out there. I haven't seen it yet, because you should never say never and you should never say always in nursing, because there's always a variable. But I have never seen a drug that should be taken with antacids. Ever. Ever, 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 ever. You should never take any drug with antacids. Okay? And I'm sure there's one out there. I just don't know what it is. True or false? Sulfonamides should not be given with cyclosporines. I feel like it's so early for my brain to figure that out.
I was like, something shouldn't be given with something, but we don't have any clue what the two were.
True.
So funny. I think that's true.
You think it's true?
True.
50.
It is
Okay.
true. When sulfonamides are taken with cyclosporines, the risk of nephrotoxicity rises. Which I feel like is mostly true for like all antibiotics, because they're all nephrotoxic. But apparently these two specifically are more nephrotoxic than the other. So before we move on from tetracyclines, the nursing considerations start on page 127, and it has all of those fun things that we just talked about. Evaluate renal and liver function tests, including a BUN, creatinine clearance, to assess the status of the renal and liver function. This is all on page 127, going into page 128. There's also a little teeny box that says key points. It talks about tetracyclines being bacteriostatic. It talks about the tetracyclines can cause damage to developing teeth and bones, and to monitor the patient for GI effects, bone marrow depression, rash, and superinfections. So please make sure you're looking at these boxes of nursing considerations. They are very much going to help you. Okay. Any questions on tetracyclines? Okay. So, antimycobacterials. These drugs are specific to treating tuberculosis. We don't really see leprosy anymore. I don't even know if leprosy is even a thing anymore. Like, I feel like that, when I think of leprosy, I think like biblical.
Mm-hmm.
So I don't actually know if there's people that actually have leprosy in 2026. I would have to Google that. But these are the first line drugs for treating tuberculosis. Your most common ones are going to be isoniazid, rifampin, ethambutol. So the thing about the treatment for TB is that it's not just like a week or 2 weeks. It's months and months and months of treatment. So the treatment for TB continues for anywhere between 6 months to 2 years. And it says using the drugs in combination help to decrease the emergence of resistant strains and to slow the life cycle. So when treating tuberculosis, it's usually in combination with its friends up here. Okay. So most of these act on the DNA of the bacteria, which lead to the lack of growth and eventual bacterial death. So in turn, they cannot survive. They're generally well absorbed from the GI tract, metabolized in the liver, excreted in the urine. Every time you see that, hepatotoxic, nephrotoxic. It is contraindicated or cautioned. Let me see which one is which. Contraindicated for patients with any known allergy and in patients with severe renal or hepatic failure, which could interfere with the metabolism or excretion of the drug. If it is necessary during pregnancy, there is a combination that is the safest. I'm not going to test you on that. I just want you to know you do have to be very cautious because we can't just let a pregnant person die because we're not treating their TB, right? Especially when there's only a very small amount of drugs that can help. So in this situation, it's going to be risk versus benefit, okay? Adverse effects include your CNS effects. Remember, anytime it says CNS effects, it's going to mean dizziness, headache, this even includes hallucinations. We have GI effects just like all the normal ones, including nausea, vomiting, diarrhea. And then it says rarely pseudomembranous colitis. Okay, so that just means irritation of the colon. Okay, but like mega irritation of the colon. Something very important to know about rifampin is on page 130 under adverse effects. Rifampin rifabutin and rifapentine. First of all, rifampin is going to be the most common out of those three. I'm not going to test you on the other two. I would only use the most common, which is rifampin. Causes discoloration of body fluids from urine to sweat and tears. Alert patients that in many instances, orange-tinned urine, sweat, and tears may stain clothing and permanently stain contact lenses. So this is the second drug we've talked about that can change the color of bodily fluids. What is the other one?
Pyridium.
Pyridium.
Iridium.
So rifampin and I think it's phenopyridium. It's not just pyridium. Well, that's azo, but there is also a drug just pyridium. But yes, both of them cause discoloration of the urine, sweat, tears, can stain your clothes and stain your contact lenses. So the biggest thing for this category of drugs is hepatotoxicity, nephrotoxicity, the long duration of treatment, which what do we think about when we're treating something for 6 months to 2 years? Compliance. Compliance is huge. Okay. If you have active TB, there are, because it's in the lungs, there's spores in the lungs. So if your respiratory is affected significantly, then yeah, you absolutely could be hospitalized. And what type of room does a patient with TB have to be in? A negative pressure room. Other antibiotics. I want to say anything about. I think I care about the fact that you know about vancomycin. Vancomycin is the first line treatment for C. diff, but it must be oral. You cannot treat C. diff with IV vancomycin. Okay? It has to be oral because it has to get to the site of the intestines to treat it properly. That it's important to me that you know that. It's also important that you know vancomycin has a therapeutic range. So you would need a peak or trough, definitely a trough, when evaluating the effectiveness of vancomycin.
Are peaks and troughs still needed for PO, Vanco?
Yes. But it's more important. She asked if peaks and troughs are still important for PO. Yes, but it's not as important as IV.
So I think that I've ever seen like in the facility I work in, I don't know that we've ever done it for PO, but it's usually just
It's not done
7
on.
days. Yeah.
Yeah. When we talk about vancomycin, there used to be, it was called red man syndrome. And it was like the biggest thing with vancomycin was this red man syndrome. And I don't know why. I don't know why they changed it, but they don't call it red man syndrome anymore. They describe all of the adverse effects, like the extremely red skin, the skin is hot. It's a reaction to the vancomycin. But they don't call it red man syndrome anymore. So knowing that your patient can have a reaction where their like entire body turns bright red, like a very intense burning red, is very specific to vancomycin and important to know. And you may or may not see it listed as red man syndrome. So one thing that you'll notice when you're in practice, and probably LPNs have been seeing this for a while, is that even though things aren't called the same thing forever, they're still referred to the same way, even in notes and charts. So if you were to look at an infectious disease note and it was talking about a reaction with vancomycin and it lists red man syndrome, I need you to know, even though it's not listed in the drug book anymore. Okay. It's listed as an adverse effect with this red flushing, but it's not called that anymore.
With the adverse effects, that doesn't mean that you have to.
You should stop. You should stop the infusion and notify the provider. Yes.
So is it side effects that you don't have to? Both of them?
If your patient experiences red man syndrome from an IV infusion of vancomycin, You should immediately stop the infusion and notify a provider. Yes.
Miss Simmons,
Yes.
you're freezing, so we missed a few of the things you said.
Well, how long has that been happening, Chastity?
It just happened. I promise. Like that whole
Well, I
little
feel
sentence.
I have gone on a tangent about red man syndrome for the last like 4 minutes. Did you
get it?
hear that any of that?
I want to say maybe not like the last minute.
4 minutes, not a minute of this.
Yeah.
I was just saying that if your patient experiences a very red flushing throughout their entire human body, if taking IV vancomycin, the infusion has to be stopped and you need to notify a provider.
Okay.
Okay?
Thank you.
You're very welcome. Okay.
Okay, excuse me.
Yeah.
Is it as a result of pushing it fast or pushing it slowly? What caused it?
No, it's
Okay,
not. I
okay.
believe, and I would have to make sure, I would have to look, but I believe it is a form of allergic reaction to
It can
vancomycin.
happen at any
It's not, it says.
It's not?
on Google that it's non-allergic hypersensitivity.
Non-allergic hypersensitivity. So there's a histamine reaction, but it's not occurring from an allergy. So it doesn't mean that they can't have it again. It just means that they're at higher risk and they probably pre-treat with probably Benadryl before they take it again.
And it says that a lot of the times it's due to the infusion being too fast.
A lot of the times it's due to the infusion being too fast. Okay, that's good to know.
I got mine 2 weeks into treatment.
Yeah, because I read
It doesn't
where
always
Yeah,
happen the
it was-
first time.
It was my last.
Like an allergic reactions usually happens quickly and during the first infusion. Again, not always, because you can have an allergic reaction to anything at any time. But red man syndrome is not specific to the first dose, the last dose. It could happen at any point during treatment. Okay. I just want you to be aware of what it is if you see it in real life or, you know, NCLEX, whatever. Miscellaneous drugs. Oh wait, I wanted to go back to let me see if there's anything about macrolides that I wanted to cover, because macrolides are a big one. That's your azithromycin, your Z-Pak, erythromycin, which is usually like an ointment. Oh my. Abnormal thinking and uncontrollable emotions. No, thank you.
For which one?
For macrolides.
Oh.
No, thank you. High doses may result in ototoxicity and QT prolongation. Like, what is it doing to me that I have abnormal thinking and irrational emotions? Like that just
Crossing the gray area.
it doesn't even say irrational. It says uncontrollable emotions. That really freaks me out. Azithromycin is your Z-Pak. Z-Paks are pretty much thrown at everybody. It's it is a broad spectrum antibiotic that say you have, I don't even know, pneumonia, some type of respiratory thing, and they think it's bacterial. They'll put you on a Z-Pak. I'm sure you've had a Z. I feel like every human has had a Z-Pak at some point in their life. It's literally like a box.
He takes
And-
2 the first day and then
Yeah,
1 for
you
4 days.
you have like 2 pills, and then it's like 5 days of pills, and it comes with a card, and it tells you like take 2 here, take 1, take 1, take 1, and it's called a Z-Pak. The only thing that could be important to like ATI, food in the stomach decreases absorption of oral macrolides, except for azithromycin. Therefore, the antibiotic should be taken on an empty stomach with a full 8-ounce glass of water, 1 hour before or 2 to 3 hours after meals. So I told you, remember, most antibiotics tell you to take with food. There's only a small handful that tell you not to take it with food. Okay, that's your doxycycline. That's your where is it? Clarithromycin and erythromycin. But it's not azithromycin. It's not your Z-Pak. It says except for azithromycin. Okay? Sometimes when you say these words over and over, they just blend into each other.
Could you please repeat the ones that we have to take with food again?
The one, so you should take most of antibiotics with food. Okay? The ones that you take without food is a
Yeah,
small.
without food.
Right. So that's your doxycycline and the other macrolides, which are on page 135, clarithromycin and erythromycin.
Okay.
Okay.
Thank you.
You're welcome. Um, so all your miscellaneous antibiotics start on page 139. I'm just making sure there's nothing in here that I need you to know. Okay, so your patient has TB. Which will the provider prescribe? A. Isoniazid. Isoniazid. ATI and NCLEX loves TB drugs. And I don't know why. It's not like it's super, like
It's a
TB
super
is not
popular
common.
infection.
I've been a nurse for 8 years. I've never had a patient with active TB. Ever. Not one time. So I don't know why they think TB beds are so important.
Maybe they're planning a comeback and they know something we don't.
They better not plan a comeback because I am not trying to play. Okay, so we talked about how smart bacteria are in resistance. Viruses are even smarter. They are very, very, very intelligent little fudgers. And they're even better at it because they can encapsulate themselves. And I think there's something called envelopes. And they can do all kinds of things that make them stronger and more resistant.
And they'll just lay their door
Which is
for 10
freaky. And they just change constantly. Like, if you didn't know, the flu vaccine, literally, they have no idea. It's just a guess. There are so many strains of the flu virus that I don't know how. It's like they have a whole big bucket of flu viruses and they say, I think it's going to be this one this year. And I think it's going to be this one this year. And we're going to make a vaccine that's going to cover just these two. And if they're wrong, sucks for us. We're mandated to get flu vaccines, right? If it works, cool. That's cool. But every single year, it adapts and changes. Every single year. And almost every virus does this because their whole goal is to survive. Okay? So viruses cause a variety of conditions. They have either DNA or RNA. We learned a lot about RNA during COVID. And RNA is just it's kind of the same type of structure, but it's within the ribosomes. They must enter a host cell to carry on any metabolic processes. So a virus can stay alive on a surface for 5 days, 3 hours, depending on the virus, right? But it literally can stay alive on a doorknob for 5 days. But it cannot go through any metabolic process, no energy production, no reproduction without having a host. Okay, so in order for it to produce, it has to have a host. The host cells die and release new viruses into the body, which is freaky. Okay, so the virus goes in, it goes inside of your cell. While it's inside of your cell, it reproduces. You ever see that video where you kill a spider and then like a million come out? That's basically what's happening with a virus. So as soon as that host cell naturally dies or dies because of the viral reproduction inside of it, all those little baby viruses comes out. That freaks me out so bad. Okay. It's difficult to develop effective drugs that destroy a virus without harming the human host, which is why you always hear the virus has to run its course. The virus has to run its course. Because if we treat you, we're going to kill you. Okay? And we don't want to kill the host. Interferons released by the host act to prevent replication of the virus. This is part of our immune response to viruses. Okay? It really sucks that they're so smart. So this is your spider laying a million eggs. This is what it freaks me out. It freaks me out. But this is just a depiction of how it works. The virus goes in, it replicates, and then it opens up the cell and goes throughout the entire body. Okay. So, our poor children are very sensitive to the effects of most antiviral drugs. We really don't want to give them to children unless we absolutely have to. Adults need to know that antivirals are specific for the treatment of viral infections. So, like we talked about on Tuesday, I'm not giving you an antiviral for a bacterial infection. I'm not giving you an antibiotic for a viral infection or an antifungal for a viral infection. Okay? And significant adverse effects on fetal development, which means we're not going to give a lot of these drugs to humans carrying fetuses. Okay? Older adults may be more susceptible to adverse effects and can cause hepatic or renal dysfunction because of the normal part of aging. Okay. The best option is prevention with vaccination. We all have our ideas and stance on vaccines. You are allowed to have them. This is a free country. Okay.
Not sure. Just
we are allowed to have opinions. We are allowed to make educated decisions. But that is the most important part, is that we make educated decisions when it comes to vaccinations. You know, do I want measles to run rampant through our country? No. Am I going to make sure my kid gets an MMR vaccine? Probably, yeah. Am I going to vaccinate him against COVID? I don't think so. No, probably not. But that's the whole point. We're allowed to make those decisions. Okay. Now, whether they're allowed to go to school or not without them, that's that's not on me. Somebody asked a question. Stupid question, probably not. Do the viruses get into MOT or all our cells, and then as infected cells die and we
Sorry.
produce new ones, and that's how we get better?
I think it's supposed to be most of them.
Oh,
Sorry.
I wouldn't say it's all cells. I think it would be more of like particular cells, which I don't know which cells those are. We produce new ones, and that's how we get better. We get better by our immune system fighting off. That's how we get better. Because when we have a viral infection, really all we have is supplemental care and treating symptoms, not the actual pathology of the disease. Which
Wait 1 second. That looks amazing.
Oh.
Wait a minute.
You look amazing.
So the action of an antiviral is to inhibit the enzymes, slow the spread, or cause viral deaths. Okay. Most of your antivirals are going to slow the progression. Okay. Slow it down. Most of them are not going to be able to kill the virus because of how smart the little devils are. Contraindications and precautions or cautions. Oseltamivir. Jesus. I hate words sometimes. But most of your antivirals are going to end in VIR. Okay. That specific drug causes renal dysfunction. You want to be very, very careful with pregnancy, breast, or chest feeding. There is very specific indications for the nasal influenza vaccine. I believe you have to be older than 2 and less than 65 to be a candidate. And it is a live vaccine. It's in here somewhere. I don't remember what page it's on. We're going to get to it because there is like a whole chapter on vaccines. So we'll get to it. True or false, treatment of a viral infection is difficult without serious toxic effects of the host. That is true. So, drugs for herpes and cytomegalovirus, they inhibit the DNA replication by competing with viral substrates to form shorter, non-effective DNA. So that means it just disrupts the way that they reproduce. Okay. Some of these drugs are highly toxic. You don't want to use them with renal disease. So this all starts on page 149. This includes acyclovir, which is a very common antiviral. Gancyclovir, GAN cyclovir. That is also a popular one. And then this one starts with a V. It's valacyclovir. It's Valtrex. I feel like Valtrex is very common. And I'm pretty sure you can buy it over the counter. 149. These drugs have shown very good effectiveness in immunocompromised patients with AIDS.
Can people with AIDS like live like a pretty long life? They're
Nowadays, people with AIDS, if they are compliant with their medications, can live a very long life. A very long and fruitful
And
life.
long. It's
Essentially very normal if they take their meds. Compliance is huge when we talk about HIV and AIDS.
I think I saw somewhere that like most of the reason that they die is not from actual AIDS. It's from what did you call it? A
Opportunistic
opportunistic
infection.
infection.
Yes, ma'am.
Because they have
Yes, that is very correct. That is very correct. Da, 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 da. This says to be cautious in patients with severe CNS, central nervous system disorders, because the drug can affect the CNS, causing headache, neuropathy, paresthesia, confusion, and hallucinations. So you would want to be careful with patients that already have central nervous system disorders. So in our nursing considerations for patients receiving agents for herpes virus and cytomegalovirus, that starts on page 151. Like a patient that already has renal dysfunction, it might interfere with the metabolism and excretion of the drug, so you have to be careful of renal toxicity. Severe CNS disorders that could be aggravated. Pregnancy or lactation to prevent adverse effects on the fetus or nursing baby. Evaluate renal function test to determine a baseline. Do you know what a baseline is? Do you know what that means? How we function without anything. So a baseline test is what is the lab result before any treatment begins. Ensure good hydration to decrease the toxic effects of the kidneys. Ensure that the patient takes the complete course of the drug regimen to improve effectiveness and decrease the risk of emergence of resistant viruses. Wear protective gloves when applying the drug topically to decrease the risk of exposure to the drug and inadvertent absorption. So if I was putting this drug on another human, I would want to wear gloves, which I feel like is self-explanatory. But, you know. Very, very heavy on the renal function. Excuse me. Avoid sexual intercourse if active genital herpes is being treated. I feel like we already know that, but it needs to be said anyways, because if people listened to that, it wouldn't get spread around.
Yeah.
So
we would be having so many outbreaks.
okay, good. Agents for HIV and AIDS. I remember there being a very important question on the exam about these drugs, and now I have to remember. There are 1, 2, 3, 4, 5, 6 different classifications of HIV and AIDS drugs. I don't need you to know each of them, okay? There's going to be an important thing, not really about the classifications necessarily. So when we talk about HIV, so the HIV virus affects what we call the CD4 cells, and they are part of our immune system. When we don't have any CD4 cells, or I believe it's less than 500.
I thought it was 200.
Is it 200 now?
When it becomes AIDS?
Yeah. And you have
That's
to
what
have
I was just
multiple
about to ask you.
and you have to have multiple opportunistic infections to be
You might be
diagnosed.
right. I don't. A 200 came to my head. You might be right.
It's either 200 or 500. I'm not testing you on it. Just know that there is a progression from HIV to AIDS. Okay.
And you find that through the CD4 cell.
And you find that through the amount of CD4 cells you have and active opportunistic infections. Because if you have opportunistic infections, that means that your immune system sucks. Like sucks real bad. She said, I remember 200. It probably is 200.
A count lower than 200
Is it 200?
the official
Yeah.
CDC definition for H.
It
or
is
stage
200.
three.
Okay, so HIV mutates over time, presenting a slightly different configuration with each new generation. Usually a combination of at least 3 different antiviral drugs is used to attack the virus at various points in its life cycle to achieve maximum effectiveness. It is extremely important that these patients are compliant. Who needs to change their battery?
I was just thinking
Somebody needs to change their battery in their what's it called?
smoke detector.
Smoke detector.
I was kind of sad when my grandpa came over.
Oh no.
It is not a soothing sound. She said, I find it soothing. So I think what I want to do is look for the box. Nursing considerations for patients receiving agents for HIV and AIDS. Because this is going to combine all of the information about all of these categories. Okay, so that's on page 159, where it starts the nursing considerations for patients receiving agents for HIV and AIDS. Evaluate hepatic and renal function tests to determine a baseline. Check results of a CBC with diff to monitor for bone marrow activity, helper T cell number. Big nursing considerations: impaired comfort related to GI, CNS, dermatological, malnutrition, knowledge deficit. And then where it says injury related to CNS, that means injury related to falls, dizziness, fatigue, falling. Okay, so it's a safety issue.
With their own
Mm-hmm. Administer the drug around the clock if indicated to provide the critical concentration needed for the drug to be effective. Compliance is extremely important. I don't know how many times I have to say that. Ensure that the patient consistently takes the drug regimen and takes all drugs included in a particular combination to improve the effectiveness. Small, frequent meals to provide protein and other nutrients. Stop use of the drug if severe rash occurs, especially if it is accompanied by blisters, fever, and other signs. And not only stop, make sure you notify a provider. Follow-up patient teaching is going to be very important. Have regular medical care, regular schedule for taking all of their drugs and the correct time during the day. Periodic blood tests for renal and hepatic CBC. They even give you a critical thinking scenario case study on page 161. St. John's wort is an over-the-counter supplement that is contraindicated in so many drugs. Okay. If
I
you
feel like
ever,
if it's ever an option on my exams, I usually just take that.
I was literally going to say, if you ever see a question and St. John's wort is one of your answers and you don't know specifically that it's a different option, I'm telling you, I bet you 9 times out of 10, the answer is St. John's wort. Same thing with grapefruit juice. If you don't know for a fact, and I didn't tell you for a fact that it's something else, bet you it's grapefruit juice. Because there's so many contraindications with grapefruit juice, St. John's wort. Okay. We already went over a lot of these adverse effects when we were talking about the nursing considerations. Renal and hepatic function is extremely important, and having baselines and routine tests. These protease inhibitors can affect the way that anti-diabetic drugs work.
And by that, does it make them less effective or more?
Hold on, I'm about to tell you.
Sorry.
Patients receiving these drugs may also be at risk for developing diabetes or hyperglycemia and may require dosage adjustments if being treated with anti-diabetic drugs. That's on page 157.
What's it hypo?
Hyperglycemia.
Less effective.
You said big one. 7.
Can you repeat that one more time, please?
Yeah. Page 157. It says patients receiving this.
Protease inhibitors?
Yeah, protease
Okay.
inhibitors may also be at risk for developing diabetes or hyperglycemia and may require dosage adjustments if being treated with anti-diabetic drugs.
Thank you very much.
Mm-hmm. So if you notice, I'm picking out things that are going to affect the majority of people, right? So when I'm looking at this with fusion inhibitors, I'm seeing it's given sub-Q. What does that mean? What do I need to do with sub-Q medications? I need to rotate the sites.
I was like, what are you asking?
I need to rotate the sites.
We knew that.
How far away from the umbilicus should you be? 2 inches away from the umbilicus. And rotate your sites. What sites can be used for sub-Q medications? Your abdomen, the back of the arm, your thigh, your butt cheeks, if you really wanted to and you got a big fat butt. Okay? Thighs are becoming more popular with all of our Ozempic girlies. And when we talk about any type of injection, you also need to include injection site reactions. Okay? Oh my. Girl,
Yes.
throwing shit.
That's how I feel. Yes.
So, for example, on your exam, if I were to discuss any of these classifications, I would say, I can't even say that drug. I'm trying to find one that I can say. um, because I do recognize this one. Zidovudine. It's on page 155. So if I were to say this, I would say your patient has been prescribed blah, 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 which is a nucleoside reversal transcriptase inhibitor for HIV. Okay? I mean, I gotta do something. What am I gonna do? Just put the drug name and then let you drown?
No.
I can't even say the damn names. Right? So the more information I can give you, I can say this is the drug name, this is its classification, I'm giving it for HIV. So at least you know this is an HIV drug, this is the classification, this is what it's called. The rest is on you, right? So if I were to ask you about that specific drug, it says this was one of the first drugs found to be effective in the treatment of AIDS. It is rapidly absorbed from the GI tract, metabolized in the liver, excreted in the urine. So it's probably hepatotoxic and nephrotoxic. Just like all of the antivirals for AIDS and HIV. I wanted to look into that lung disease. Lung disease.
So with HIV medicine, we're not looking at the medicine per se, like the names, more so just the classes, correct?
Yeah. She said for the HIV meds, you're not really looking at the names, you're looking at the classifications. Yes, correct. Because the names, they don't really have a prefix, they don't really have a suffix, they don't there's no trend, right? And I don't want you spending an extreme amount of time looking at all of these individual antivirals. Because then you're just, it's too much time going into a very, specific area, right? Like if we were talking about GI meds, that's a huge thing. We're talking about one classification, like one little piece of the pie. And I don't want you spending an exorbitant amount of time on one piece of the pie. Oh, it just says that it's associated with pneumonia. That's all. The lung disease threw me off. Here's St. John's wort again. St. John's wort again. They all say liver failure. They all say renal impairment. This one includes suicidal ideations. So you're caring for a patient who has been diagnosed with herpes simplex and is given a prescription. What should you teach this patient about taking their medication? It's definitely not going to be D.
And not A because it says decrease rate. Oh no. I think it's C.
It's probably not going to be A because a topical herpes drug, you don't put an absorbent pad over top of it. So it's either going to be B or C, in my opinion.
I think C.
The answer is C. Administer the drug as soon as possible after the diagnosis has been made to improve the effectiveness of the antiviral activity. So basically, get to it as fast as possible before all of the viral replication happens. Try to nip it. You're caring for a patient with HIV. The patient says they are experiencing pain at the site of injection. What type of drug is this patient taking? This is a quality question. You're not looking at any of the actual drug names. You're looking at the classifications. And which one did we say was sub-Q? She thinks it's B. Anybody else?
It's B.
Transfusion.
It's B. Because this drug is given sub-Q.
Wait, that's A.
Oh, I'm sorry. A.
But
Wait.
That is answer B.
it's B.
Oh, it is the the answer is fusion inhibitor. Which is correct. All of the other drugs are given PO. All right, anti-hepatitis. I say we take 10 minutes. I gotta pee and I need a drink. 10 minutes.
Miss Simmons, are you purposely muted?
Yes, I wasn't talking about anything school like class related.
Okay, sorry.
No, you're fine.
And the hardest part, they say they made a story and then they can't get.
Oh, yeah.
Listen, I.
Okay. Let's get back on track. So, hepatitis B. So all of us, because we're all sitting in this room or online, are vaccinated against Hep B. And it's a 3 vaccine series. But there are drugs that can help us fight off hepatitis B. Hepatitis B is a serious to potentially fatal viral infection of the liver. It can be spread by blood or blood products, sexual contact, or contaminated needles or instruments. The reason we so specifically have to be vaccinated is because healthcare workers are at especially high risk for contracting Hep B due to needle sticks. I don't think I've ever heard a nurse ever say, "Oh yeah, that's totally going to happen to me," regarding a needle stick. Most of the time you're always going to hear a nurse say, "That's never going to happen to me." And guess what? It happened to me. It 100% happened to me. And I could not believe it. It happened so fast. It happened so fast, and I couldn't believe it even I literally stood there and I was like, holy shit, did that just happen?
And then you're like, wait, did it actually?
I was getting an arterial blood gas. I was working in the ICU, and some people are just really, really hard to get, especially if they're on vasopressors and their cardiovascular system is just clamped down. I mean, I'm talking very, very intense vasoconstriction. And your radial artery is, I mean, it's pretty small. So when you're very vasoconstricted, it can get even smaller. And I should not have went back in and tried again. I should not have. But I was cocky, and I'm usually very good at getting gases. So it kind of pissed me off that I couldn't get it. And I got cocky, and I was like, I'm gonna get it. Like, I'm gonna get it. And I took the needle out, and I went to go put it back in, and I sucked myself. I stuck my finger. And I was like, I literally stood there so shocked and stunned and was like, oh my God. Ripped my gloves off. This is called milking. So like if you ever were to get stuck, you should push the blood out like this, like push it out. I mean, is it going to really help you? It can. It sure can. And neither the patient nor I had Hep C, and contracted it to each other.
So
But it was really, really scary.
go to the facility or wherever.
You immediately go to employee health. Well, after you milk it, wash your hands, notify your charge nurse, hey, I just got stuck with a needle and I have to leave. Because you can't just leave, that's abandonment. Then you need to go to in this case, I don't think I went to the ER. I think I went to the employee health nurse. And she did all the lab work and the follow-ups. But every facility has the proper way on how they handle it. You just have to make sure you do it the proper way. There was another time where this was not a needle stick. There was a patient, we were trying to irrigate the bladder, and he had, it was so difficult. We had this huge 60 cc syringe, and we were trying to irrigate with saline, and there was no urine output. We couldn't get anything back. Thank God I had my glasses on. Thank God I had my glasses on because that syringe popped off and I got sprayed in the face. And he did have Hep C. And that is when I was really like, oh, this was my very first year of nursing. Oh, I was hysterical. I was hysterical. I literally ran to the sink, ripped my glasses off. I scrubbed the shit out of my face. I was hysterical. I do not have Hep C. Did I leave his room? He died 2 hours later.
Oh my
He coded and died 2 hours later. His kidneys shut down. And there was no urine output, and that's why we couldn't irrigate the bladder and the Foley, and it was a mess. And I never be cocky. Because I'm telling you, cockiness got me in both of those situations. Both. Because I was like, oh yeah, I do this all the time. I was so cocky my first 2 years of nursing. Like I was seriously, like you would have been like, and I mean, over time I got humbled, obviously. But like, you need that. Like you need that humbling. Because the second you get cocky, the universe is like, bet.
Watch this.
Bet. Because I'm about to spray Hep C urine in your face. And the reason that I say that is because it was pink tinged and it was bloody urine. So, because normally urine just doesn't carry Hep C. Okay. But, anyways, don't get cocky. Next, moving on. So, hepatitis B, Jesus.
You're cute.
Is metabolized in the liver, excreted in the urine, just like all of our antivirals are nephrotoxic and hepatotoxic. You're always going to have increased risk of, renal toxicity if you combine a bunch of other nephrotoxic drugs. I mean, that's just, it's just it. So there's nothing really specific about Hep B drugs that's any different from any of the other antivirals. In the nursing considerations for patients receiving anti-hepatitis B agents on page 164, it talks a lot about assessing the patient, assessing for renal and liver impairment, for pregnancy and lactation, baseline data. 164. The only difference I see is it says withdraw the drug and monitor the patient if they develop signs of lactic acidosis or hepatotoxicity because these adverse effects can be life-threatening. That is the only thing that's sticking out to me that's different than the other pages that I've read. This is really, this is something you should just live by anyways. Report severe weakness, muscle pain, palpitations, yellowing of the eyes or skin, or trouble breathing, right? So severe weakness, that could mean a lot of things. That could be your CNS. That could be electrolyte disturbances. That could be organ failure. That could be a lot of things. Muscle pain specifically for the lactic acidosis and rhabdomyolysis. Palpitations is most likely going to be related to an electrolyte disturbance. Yellowing of the eyes and skin, jaundice, that's going to be hepatotoxicity, liver failure. And then trouble breathing, that's obvious, right? ABCs. If you have trouble breathing at any time, anywhere, you should probably tell someone and go to the ER. Okay. Hep C starts on 165. I'm pretty much just going to do the same thing and look for any outliers because otherwise all your antivirals are going to fall in the same box. Okay. This definitely says St. John's wort. So we saw that on multiple pages. Okay. For Hep C in the nursing considerations on page 166, it says advise patients that there is still a risk of transferring the disease and that viral cure is assessed weeks after treatment. If you didn't know, hepatitis C is curable now. My dad had Hep C. And he was actually one of the first people that was ever cured of Hep C. And it used to be an injection he had to take an injection every day for a whole year. But now the treatments are much, much, much shorter. Much shorter. I don't know what it is, but it's much shorter. And hepatitis C is curable. But it does say that there is still a risk of transferring the disease and that the viral cure is assessed weeks after the treatment is ended. So the patient should continue to take appropriate steps to prevent transmission of hepatitis C, even after they're cured. Okay. How long does that last? I don't know. But it says at least a couple weeks. Okay. Okay. So locally active antiviral agents, this is your Abreva. This is the stuff that you can buy over the counter or prescribed that you can put on topically. Okay, do we all know what Abreva is? You know, it's for cold sores. You can buy it over the counter. It's like a little tube of ointment and you could put it on the cold sore and it'll like stop whatever. So that's what these drugs are. When we say locally active, that means it's only working on a very small place. Like it's not systemic, the whole body. It's local to one place. Locally active antiviral drugs are not absorbed throughout the system systemically. So allergic reactions usually happen like around where you put it. Yeah. And they're usually dermatological, like a rash around the site.
So if it says don't apply to open, wouldn't those blisters be considered?
She said it says do not apply to open wound, and wouldn't you think that an open cold sore would be an open wound? I don't know. I don't know. I've never had a cold sore. I've never had to treat it.
Yeah.
So I don't know.
Like they
To be honest with you.
you don't use the Abreva until it's capsules.
I don't
know.
I have no idea.
I know how you
use
use it.
them all the time.
My dad actually takes because he gets cold sores too. He takes an antiviral every day, like a pill to prevent cold sores.
So that's let's see page 57. It say let's not get different.
Mm-hmm.
But it say treatment of red turn post.
Mm-hmm.
And then what am I trying to say? So basically they were giving us that it was giving that for like
Acyclovir for COVID? Yeah, because here's the thing. With COVID, we didn't know what we were going to do, and we just kept throwing stuff at the wall to see if it would stick.
yeah.
I mean, we were like drowning our patients in vitamin C, ascorbic acid. We were drowning them in zinc,
Yeah.
the monoclonal antibodies, the
Who is the one with 3? Am I the one with 7 there? It's the we have to give or 3.
I don't know.
I feel like it's
I don't remember. I try to block out those days because it's very traumatic for me in my brain. Okay. Which antiviral drugs are not absorbed systemically? Locally acting.
B.
Two 2:30 today.
Okay. Ask you a quick question. Yeah. We have bacteria going at 7 o'clock. Are we for sure gonna keep it separating minutes between 3 o'clock?
Yeah, it's for sure separate. Yeah.
She's like, I got baby calls.
I got a kid at home too, and that kid does not like when I work. Okay, chapter 11. Antifungals. So, how does a fungus differ from bacteria? It is composed of a rigid cell wall made of chitin and various polysaccharides and a cell membrane containing ergosterol. Very, very just too much science for me. Protective layers of the fungal cell make the organism resistant to antibiotics. So just think they have an extra coating that antibiotics can't get through. Okay, so antibiotics don't work for them. They need antifungals. So bacteria are resistant to antifungal drugs because of their cellular makeup. Patients that are most susceptible to fungal infections are going to be your immune compromised patients. So your patients with HIV/AIDS, taking immunosuppressant drugs, transplantation or cancer treatment, because chemotherapeutic drugs and transplant drugs lower your immune response. And then members of the growing population of older adults, they have diminished protection from environmental fungi. So older people they get thrush more often, right? Do we know what thrush is? Oral candidiasis, yeast in the mouth, okay? Systemic, the whole body, antifungals. These are drugs used to treat the systemic infection and can be toxic to the host because it is given to the whole body. A culture should be obtained to make sure that we're using the right drug. And patients should not be put at additional risk for toxic adverse effects. That means whatever you need, we're not giving more than what's necessary. Okay. Oop. Azoles. Azoles are, I feel like, are your biggest antifungal classification and most common. So this is your fluconazole, which is diflucan for yeast infections. Fluconazole. Ketoconazole is very common. I'm on page 172, by the way. These are the most commonly prescribed azoles. Ketoconazole can be a shampoo, it can be a cream, topical. It's extensively metabolized in the liver and excreted through the feces. The biggest thing for me with azoles, and this is page 175, have been associated with severe hepatic toxicity and should be avoided in patients with hepatic dysfunction to prevent serious hepatic toxicity. This is also very important. In addition, ketoconazole is not the drug of choice for patients with endocrine or fertility problems because of its effects on sex hormones. Ketoconazole is not the drug of choice for patients with endocrine or fertility problems because of its effects on sex hormones. Male patients can have gynecomastia, decreased libido, or erectile dysfunction. This is all on page 175 under contraindications and cautions. Female patients may have irregular menstrual flow. Azoles are associated with liver toxicity and can cause severe effects on a fetus or a nursing baby. So it's a no-go. Pharmacy diflucan, and he said, "You take Lexapro," and he goes, "Lexapro and diflucan can prolong your QT interval," and I was like, "Nobody's ever told me that," and I've taken this combination multiple times, and nobody's ever told me that. So that kind of stuck in my noggin a little bit and just reminded me, because under clinically important drug-to-drug interactions, it says that it can cause a prolonged QT interval. This classification, your most common medication is called micafungin. It's a fun word. MICAFUNGIN. Micafungin. I've given it only a couple times. Again, hepatotoxicity. This one has bone marrow suppression. One of the most important antifungals nystatin taken orally is used for the treatment of intestinal candidiasis. First of all, I don't even feel like we looked at nystatin.
That would be true, but he's not consistent.
It's the orange that's on the side.
So can be swish and swallow or swish and spit.
Yeah, so I think it's true.
It is true, but we didn't even talk about nystatin yet, and I don't feel like it's fair that they asked us a question on nystatin without even talking about it first.
Maybe because it's used to treat thrush.
Yeah, but we didn't even talk about it yet. It's literally on the next page. Yeah. Okay, so other antifungal agents. There are two very important drugs on this list, and one is nystatin because it's extremely common, and two is amphotericin B. Bless you. Oh my, bless you. That's such a cute little. I don't know what that was. Okay, so on page 176, well, 177, I'm looking for something very important. Amphotericin B is extremely rough on the kidneys and liver, and you have to have routine creatinine levels drawn. It can be used successfully during pregnancy, but it should be cautious. And it should not be used during lactation. So it can be used while pregnant, not during lactation. Adverse effects of these drugs are related to their toxic effects on the liver and kidneys. Patients should be monitored closely for any changes in liver or kidney function. Bone marrow suppression has been reported. Amphotericin B is associated with severe renal impairment. You should not take any other nephrotoxic drugs, such as nephrotoxic antibiotics, antineoplastics, or cyclosporines, because they're all severely nephrotoxic. You want to make sure you get a baseline labs for kidney and liver function. Monitor IV sites to ensure that phlebitis or infiltration does not occur. Treat appropriately and restart the IV at another site if phlebitis occurs. Be sure to use a large vein for infusions. That's on page 178 in the nursing considerations for amphotericin B.
So the amphotericin is only for IV. It can't be given orally.
Yeah, it's available in IV.
What page again? Sorry.
178.
Thank you.
So topical antifungals, these are going to be your drugs that you can either get over the counter or prescribed. Ketoconazole can be given topically. Lotrimin, which is clotrimazole, that's for athlete's foot. Miconazole. Miconazole can be given as a powder or an ointment. I'm sure if you work in the hospital or long-term care, we have those little powder bottles of miconazole that you just pour in everybody's abdominal folds. These can cause irritation, burning, rash, swelling. It's going to be a local reaction most of the time because you're treating it locally because it's topical. It's not going systemic. Which of the following is considered a contraindication of ketoconazole? First of all, this question sucks. Because renal and hepatic is valid, right? So which one's more important? Your
And
kidneys,
more
your
specific to
fertility,
that drug.
or your
B.
liver? Let's find out. B.
B.
It is not the drug of choice for patients with endocrine or fertility problems. So with this question, all it says is hepatic problems or renal problems. It doesn't say renal failure. It doesn't say severe renal impairment, right? So if it was severe hepatic failure, then I feel like that would change where you would go with this question. But because you can use it with caution in patients that have renal and hepatic issues, not meaning failure or severe impairment, then fertility problems has to be the answer. So nursing considerations for patients receiving systemic antifungals. Obviously, liver and renal dysfunction. You want to make sure you get a culture of the infected area, and you want to make sure you have a baseline for your kidney, liver, and CBC. And with amphotericin B, you want to make sure you're looking back and getting routine tests to make sure that the kidney and liver function is not getting worse after treatment has started. So this is just taking a closer look at fluconazole. This is diflucan. This is for the treatment of oropharyngeal, esophageal, and vaginal candidiasis. Clotrimazole. This can be used for the treatment of oropharyngeal candidiasis, prevention candidiasis. It can be used locally for vulvovaginal, so yeast in the vagina. And then topical treatment for the toes, athlete's foot, tinea pedis, crew, blah, 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 all those words. Ooh, that's a good one. Down here at the bottom, for adverse effects, vaginal, burning or irritation in sexual partner. First of all, if I'm using this on my vagina,
There's no.
the last thing I want to do is have sex with anyone. Okay. But if you were to do that, it can cause burning or irritation in your partner. If you did that. No, just okay, which is the answer, I believe, to this question. So the nurse is caring for infection, which of the following would be considered an adverse effect of a topical antifungal medication? It's not the other three because this is topical, not systemic. Okay. Stevie, your face is so funny right now. Yeah, some of these, especially these ones coming up, we're going to be flying through. All right, antiprotozoals.
Read my mind. I'm like, that was bad.
Antiprotozoals, chapter 12. So, this is infection caused by a protozoa. So insects carry diseases, they bite us, they give us the disease. This includes malaria, which is your biggest one. Ingestion or contact with the causal organism. Amoebas. We've heard of like brain eating amoebas, right? Giardias. That is most commonly in dogs or animals, but humans can absolutely get Giardias. Trichomonas. Trichomonas usually affects the vagina. It is a sexually transmitted disease. And I think it can be given other ways, but most of the time it can be given sexually transmitted trichomonas. Yes. Yes.
It goes under the microscope.
Ew,
Have you ever
Carissa?
I think it's
microscope? We used to, the old office I used to work for, they used to make us look at urine samples under the mic, and you can always tell we had trick because it moves. It's a little fast little thing.
it's one of the only ones to be
Stop it.
diagnosed.
I can't. This. No. Don't talk to me anymore about wk3.
Stacey.
I gotta hate that. I'm so. Ugh. Okay.
Your
So
vagina.
it's different than like chlamydia.
Yeah.
Diarrhea.
It's a
Trichomonas is caused by a protozoa,
It's
which
a-
is an organism.
alive.
Chlamydia and gonorrhea are caused by the bacteria of the chlamydia bacteria, the gonorrhea bacteria. Trichomonas is caused by basically
It's a
a parasite.
microscopic parasite.
Yeah.
But be careful, because like she said, you can.
You can get it from other
Because
things.
I have a client and I would like rub his head.
Ew.
Got it from his scalp. You can feel it crawling under your.
Shut up.
No, stop. Disgusting. Sorry.
I'm gonna have to walk away.
It's so nasty. It was the worst thing that I ever experienced. I wanted to kill myself.
You got it in your fingers?
And then it's great.
Scabies?
There's a lot of.
I feel like that is more scabies-ish, but
You could feel it crawling on you, and it was scabies. And I got it to rub his head because I would be the only thing that would keep him quiet because he was like abused as a child. So I rubbed his head, just make him feel better, and then I got it.
Yeah, scabies are little bugs that burrow under your skin.
Is that what it was?
That's scabies. Scabies,
you guys.
and you can have scabies outbreaks in nursing homes.
Oh, yeah.
You can have scabies outbreaks anywhere, schools, nursing homes, anywhere that you have close contact with people because it's a skin to skin like contact.
Yeah, that's it.
Oh,
Sorry, I
Done.
confused. Sorry.
I'm done. Okay.
you don't have a
Gotta be a dirty person to get.
No, it's not about being dirty. Oh no. No. It's not about being dirty at all. Yeah, not at all. It's if you are unfortunate enough to be in a situation where you can contract this, it doesn't matter whether you are a clean person or a dirty person. As soon as the hygiene of your body is not going to save you from an infection. You know what I mean?
Yeah.
You could be the cleanest person in the world and get any disease.
you could be with somebody who says
You
"I'm
could
never
be
with anybody.
it's all you know what you do, you don't know what another person does. So all that has to happen is one person has to go be with another person who has some type of something that's going to contract, and then you have contact with that person, and then it's just they have sex with a person that has trichomonas.
Like, are you asking how does the first person, like, who
Ever.
started it?
The first person ever?
They might.
Okay, that's like
They might
very
be dirty.
biblical. Like chicken was it the chicken or the egg? Like which came first? Girl, I didn't know.
Chicken or what?
Yeah.
Where did the trichomonas start?
I'm gonna Google. We'll see what Google says. You continue.
I'm sorry.
No, you're fine. You're fine. I have no idea. There's not going to be an answer. Okay, so, I don't know if I need you to know the difference of these causes of malaria. It's most important that you know that malaria is usually carried by mosquitoes. And as a American, or someone that lives in America, if you were to travel to a country that has a higher risk of malaria, you will have to take drugs, and get vaccines and do all kinds of things before you go to that country because they have, that country can have more diseases that we don't see in the US, so you don't already have antibodies against them. So you need to be pre-treated before you go to other countries that they're prevalent. It's the Ovale, caused by two different species, both most prevalent in Africa. Mosquito has developed resistance to insecticides.
Also, like the spray doesn't work on it.
So that means like we're having a hard time killing the mosquitoes that are infected.
Okay.
Yeah.
Thank you.
It says it's thought to be a bird to human jump from
Trichomonas is from birds.
ancestral pigeons and doves.
Well, now I hate birds. Just kidding. I like birds.
That's what it says.
Henry told me yesterday that he wanted to be a bird so he could fly.
Oh,
And I was like,
don't let him fly on anything. He'll be on the top bunk trying to jump. I can fly.
okay, signs and symptoms of malaria is related to the destruction of red blood cells and toxicity to the liver. The treatment, we need to kill the parasite. And if you don't know, bugs, organisms, just like humans, just like any living thing, has a life cycle. So you can kill the eggs, but that doesn't mean you kill the actual bug. You can kill the bug, but that doesn't mean you kill the eggs. So you have to treat a lot of these things during multiple life cycles of the organism. If you haven't noticed, I really, really dislike bugs. Like a lot. That's why I don't go camping. Anti-malarials. Now, these drugs can be used for other things other than malaria, which is why it's so important, for you to learn about them. Specifically, hydroxychloroquine, which is Plaquenil, is a very popular anti-malarial drug. It can be used for autoimmune disorders. And it has been very helpful for people that have immune disorders, rheumatoid arthritis, things like that. So that is going to be the most common medication on this list, is the hydroxychloroquine and the chloroquine. Contraindications and cautions: liver disease, alcoholism, which can lead to liver disease, pregnancy and lactation, retinal disease or damage. Many of these drugs can affect the vision and the retina, and the likelihood of problems increases if the retina has already been damaged. So it can hurt your eyeballs.
Doesn't it also cause like ringing in the ears or something?
I don't know. Let me see. I haven't seen that yet.
I've been taking Plaquenil
I'm
for
on
like
page-
3 years and it's never given me ringing in the ears.
Yeah. Stevie, do you mind me asking what you take? You have an autoimmune disease?
I have
Disorder.
rheumatoid arthritis.
They should be used with caution in patients with liver disease or alcoholism because of the parasitic invasion of the liver and because of the need for hepatic metabolism to prevent toxicity. So you have to remember, if you're taking this drug for malaria, then you have to think about the parasitic invasion of the liver and how that affects the liver. If you're taking hydroxychloroquine for RA, like Stevie is, she doesn't have to worry about parasites. I mean, yes, she still has to worry about her liver and make sure that her liver function is adequate, but she doesn't also have a parasitic infection that is going to be making it even more harmful for her liver. I'm just assuming that you don't have parasites, Stevie.
So when you go over to these different countries, they tell you what you need to get.
Yes, when you go to other countries, you have to follow a very specific protocol. And then when you come back, you have to follow that protocol, depending on the disease in the country. See box 12.4 for cultural considerations. NCLEX loves cultural considerations. Page 192. Patients with glucose 6 phosphate blah 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 G6PD deficiency, which is more likely to occur in people from Africa, the Middle East, and South Asia, may experience a hemolytic crisis if they are taking chloroquine or primaquine. So that could be very, very deadly to those people. Hemolytic crisis, that would be very bad. So adverse effects include CNS and immune reaction, because why is it used for autoimmune disorders? Because it stops the body from attacking itself. It decreases the immune response. So we're going to see immunocompromised, possible immunocompromisation. So these patients may get sick easier. Visual changes, including possible blindness related to, oh, this does say ototoxicity. Yes, it does. Retinal damage and ototoxicity may occur. Okay. Hydroxychloroquine can lower the seizure threshold. We talked about that on Tuesday. Therefore, it should be used with caution with other medications that are known to also lower the seizure threshold. Epileptic, so anti-seizure medications may be less efficacious, which effective, if co-administered with hydroxychloroquine. I'm not going to get into the specific types of malaria because this is pharmacology, not like pathophysiology. So I don't need you to know the specific types of malaria. But this is true. 216. Hold on, let me take this call. Hello. Can I ask who's calling? Oh.
Yeah, I feel like she's a bunch of meds, right? All these meds. You would think this would be the base of the class, enough meds, but it's not the base of the class. Class is more so body focus.
Yeah, like the farm class isn't pharmacology here. This one's so weird.
That's why I'm like, why are you telling us all this?
Yeah.
Because you're supposed to be on, you're just focused on the body and the. That's absolutely. It's a lot, but I think it is a combination of both.
Yeah.
You know how the drug works.
See, I think
Yeah. Versus just a fellow.
that's the advanced part of it. Yeah.
Right.
Like our first pharmacology class should have been classifications and learning the basics, which it wasn't. It was weird.
It was the 1994 pharmacology was started.
Yeah, like it was so weird. And then you learned, like when we took it, it was specific drug. I remember it was to treat Parkinson's, to treat schizophrenia, and like
Parkinson's gets on maybe anticholinergic.
yeah.
But yeah,
Yeah.
the
But
first
like
one,
the basics, like this is why you're giving antihypertensives, and this is how they're classified, and this is how they work. That should
that's
have
what
been
they
vague.
did.
Yeah,
Should have been.
it's all set up weird here.
It should have been. Okay, we've learned these meds.
Now
Now
this
this
is
is where
how
they
they
were in the
work.
body.
This is what your body does when you take loop diuretics. This is what
Right.
like
So the other thing is both, but it's because it's like
we miss that basic, so they're kind of
just like it's they need to insert a medical terminology, but it was important nurses.
they do.
They
That
don't
should be part of your
especially if you're not doing LP.
if you're bridging, you don't take it, but as the full course, the gen eds, you should absolutely take it.
So I should probably study that for our final.
Period.
I mean, you should, yeah, just in general, yeah.
Because if you read in some of these orders,
I don't know necessarily for
you read Chinese.
Last test. 70s because could have sworn the book test I was taking, I didn't.
Yeah, this
I don't, your point, thanks. Okay, sorry. So sorry. That's okay.
It was a clinical instructor. All right. Make sure you're looking at the nursing considerations for patients with anti-malarial drugs. Risk factors for protozoal infections. This does not include trichomonas because, like we said, that is a sexually transmitted disease. But all of the other things, the amoebas, the giardias, those are all caused by like really dirty water and really dirty, like I believe giardia is, and somebody, if they know different, correct me if I'm wrong, is passed from animal to animal because of their feces. And then animals do animal things, right? Well, and then, we go pick up their dog poop and then, you don't wash your hands or whatever, you rub your nose, you go eat your food, boom, you have giardia. Okay. Transmission happens very easily. So, and poor hygiene practices, that can go literally, it's not that you don't shower every day, it's that you're not washing your hands properly. That is poor hygiene. Okay. So it doesn't have to be you're a dirty birdie. No, you just don't wash your hands. Okay. Other protozoal infections, we talked about amoebas, trichomonas, giardias, toxoplasmosis. What is that?
Cat scratch fever.
Cats. Kitty cats. Which, by the way, who should not be caring for kitty cats? Pregnant women, because of the risk of toxoplasmosis. Okay? Because what is contraindicated? The treatment. The treatment can kill your fetus deletus, and can hurt you, the host. Okay?
Is that the same thing like with the litter box?
That's toxoplasmosis, yeah. Yep. On page 195, I wonder if this is in here. Excuse me. No. It shows you the life cycle of things. So, environment, a contaminated food, water, or hands, you ingest whatever it is. It goes into the body and it does all of its reproduction, all through its different life cycles. And it's saying that metronidazole can work in many different places. Metronidazole can work in the intestines. It can work in the bloodstream. And it can work in the liver, lungs, heart, brain, or spleen. Metronidazole is another very important drug. which is Flagyl. It is very common. Metronidazole is very common. I would say it's the only common medication on this entire list that you're actually going to see in practice. It is for the treatment of amoebas, trichomonas, and giardias, but I will say metronidazole definitely has other off-label uses because you see the use of Flagyl a lot. Metronidazole also can be used for the treatment of bacterial vaginosis. What is a huge patient education aspect of metronidazole? Who sent me? No, who sent me the pharmacology like little list thing yesterday that I was like, oh, I love this. Who was that? Tony?
You
It's
want to
on.
avoid alcohol.
Say that again.
You want to avoid alcohol while taking the medicine.
Yes, you want to avoid alcohol. It can cause I think it's called disulfiram reaction, which means you will have very intense vomiting and diarrhea if you mix metronidazole and light bulb and alcohol. Okay, very, very important.
You said causes vomiting blood. Sorry.
Very intense vomiting and diarrhea. Patients are advised to avoid alcohol for at least 3 days after treatment has ended. So, and usually when you take metronidazole, it's for like a whole 7 days. So you're not drinking alcohol for at least 10 days. Okay?
And you said 3 days after?
Mm-hmm. Because it's usually like a 7-day treatment. So then I just went 3 more days and gave 10.
Just so you know, the light bulb was with BB, not trick. It's okay.
I agree because I've been there. Yeah, without trichomonas. So, I would say that's one of the most important things to know about metronidazole is the alcohol thing. Nope. That's why you should read the little labels and the inserts that come with your medication.
You got real drunk that night, huh?
I don't think you understand it. I'm not gonna.
No, it's really like when I say vomiting, I'm talking severe because disulfiram, this drug right here, disulfiram, that is a drug that you can take that will stop you from drinking alcohol. And the reason it stops you from drinking alcohol is because it will cause you to vomit excessively.
Like 2 days.
So when we say a disulfiram reaction, it is the same thing.
Gotcha.
Yeah. Gotcha. It is extreme. When are antiprotozoal medications contraindicated? CNS. Contraindications are known allergy, pregnancy, CNS disease, and hepatic disease. When should anti-malarial medications be used with caution? Oh,
C?
good. The answer is C. Antimalarials should be used with caution in patients with liver disease or alcoholism, both because of the parasitic invasion of the liver and because of the need for the hepatic metabolism. And for this circumstance, our most common medication is going to be our hydroxychloroquine. Oh, this is the worms. This is the one about the worms. we are not spending a lot of time on this. We're gonna finish this very quickly and then we're gonna take, I don't wanna take a lot of time. Is 20 minutes okay for lunch? Instead of 30? Okay. These are worms. Pinworms, whipworms, threadworms, hookworms, all of the nasty, nasty worms. Okay. We do not normally deworm humans. It's a very specialized thing. A lot of people are trying to deworm themselves nowadays. And taking like ivermectin that was meant for their animals and deworming themselves, or like buying it off the internet from like some rando place and then like ingesting it, which is crazy. Okay. Let's not buy random drugs off of the internet and ingest them. Tissue invading worms. The life cycle of a worm, it's the same as a parasite, okay? It's very, very, very similar, except this one usually comes in either food or an injury to the body. It can happen either way. Obviously, you want to be careful when you eat any raw food, especially raw fish. Now, that happens a lot less these days because when you talk about the ingestion of raw fish, when that fish is caught, we have a way, it's called flash freezing, which means these animals are frozen literally like almost immediately. So any type of infection that they have or parasite or whatever is usually killed during that flash freezing process. So these illnesses that you can get from eating raw fish are extremely lower than they used to be before the flash freezing.
So you can also get worms, because my little sister did back in the day. If like you have a sandbox outside.
Sandbox, yes.
And you
Oh yeah.
cover it,
Oh yeah.
them kids are getting worms.
And then ringworm from like, you know, your little, well, boys and girls wrestle these days.
Yes, they do.
But the sweaty mats, you know, if they're not cleaned properly, the floors in the gym, that's where these things kind of like run rampant. Okay. So pinworms, oh God. It freaks me out so bad because the way that you can tell if your kid has a pinworm is that you put a piece of tape over their butthole at night, because the pinworms come out at night. So then when you take it off in the morning, the worm will be stuck to the tape. And that's how you can, I swear on my life, I swear on my life.
If they get really
It makes me like nauseous even talking about it.
Like regular Scotch tape?
Yes, regular Scotch
Yeah.
tape. And because the worms make your butt really itchy.
So if they're itching a lot, you clean them.
Yeah, like if your kid is just like constantly digging at their butt and saying that their butt is really itchy, they may have pinworms. Yes, it comes out in their poop. Yeah.
Can I
What?
say it's unfair to talk about this before lunch?
You know what? We are nurses, girl.
And if
We
you're
are
not
nurses,
yet, you will be
girl. I will tell you, I can talk about basically anything and give care to basically anyone and go eat a meal. I can even talk about it while I'm eating, but I will tell you that worms and bugs hold a different place. They do something different to me, and I don't like it. Anyways, treatment, so a lot of these end in azole too. I do not want to test you on these things. I really don't. I would say the only thing that I would like you to know about these drugs is that their adverse effects include renal failure and bone marrow depression. You would want to avoid other drugs that cause immune suppression with these drugs because you don't want to cause extra immune suppression. Okay. Ivermectin is the drug that I was telling you that people are trying to buy this off the internet. They're getting it prescribed to their animals and they're taking it instead of giving it to their animal to try to deworm themselves. Every one of them says renal and hepatic disease. Contraindication or caution with renal and hepatic disease. This one specifically says the safety is not established for children that are less than 2 years old. So that would be important, especially because pinworms affect children that in like their toddler, if they're in daycare. So like there's daycare years, kindergarten years, because they don't wash their hands and then they touch each other. So patient teaching about managing pinworm infections. You want to keep the nails short, hands well scrubbed, shower in the morning to wash away the ova deposited in the anal area. That means the eggs.
Yeah.
Change and launder the undergarments, bed linens, and pajamas every day. Disinfect the toilet seat. So this can even be passed from the toilet seat. Disinfect the bathroom and the bedroom floors and wash hands vigorously after using the bathroom. I don't care about that. Care about that because I'm not going to test you on these beds. Okay. Good luck eating lunch. I hope it's delicious. I'm going to go eat some mac and cheese. And we will start with anti-neoplastics, chapter 14, chemotherapeutic drugs, when we get back. So 12:20.
Come on, outside for Scully. Let's go.
There's
like a long time ago. And for some reason it prints like all 14 CRCs for like
you guys just gonna let these girls do it all on their own.
I don't know that there's much. I mean, just saying. It should almost like an energy drink. Yes, yeah.
I mean, it's something. Things that you have to write down.
So this is chapter 14, anti-plastic agents. So this is all cancers start with a single cell that is genetically different from the other cells in the surrounding tissue. So we have the possibility of making a cancerous cell at every second of every single day, which is super scary. Very, 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 very scary. I mean, we have billions, if not trillions, of cells in our body. And all it takes is for one thing to go wrong. And that's how you get cancer. And then that cancerous cell multiplies and multiplies and multiplies and multiplies until you have a big old fat tumor. Okay? Now, whether it's fast or slow, it all depends on the cell and the type of cancer. But that is basically how any cancer starts. So, anaplasia, that is the loss of cellular differentiation and organization. Every cell in our body has a very distinct differentiation and very distinct organization. A breast cell knows it's a breast cell. A heart cell knows it's a heart cell. It follows the directions that it's given. Anaplasia is when there is the loss of that differentiation. It is no longer a breast cell, no longer a heart cell. It no longer follows the rules of its organization. And it leads to the loss of the ability to function normally. Because in a normal cell, our cells divide, reproduce, and then they die. And then they divide, they reproduce, and then they die. Well, these cells, and by the way, they only divide, as many times as they're allowed. These cells, they don't care. There's nobody telling what to do, where to go. They're like, I'm going to make as many babies as I want. So when they're only supposed to have 2 babies, they have 1,000. Okay. Autonomy. Cancerous cells grow without the usual homeostatic restrictions that regulate cell growth. Okay. So that's why cancerous cells have different shapes. They look different. They group differently. So the loss of control allows the cells to form a tumor. Metastasis. A lot of people don't understand exactly what metastasis is. Metastasis is cancer cells that travel from the place of origin to develop new tumors in other areas. So when I tell you that my mother had metastatic cancer 5 times, yeah, that means that her originating tumor was in the breast. She has had metastatic breast cancer with mets to the lungs, the heart, the brain, and soft tissue. So metastasis is when the originating cancer cell, whether it's breast, whether it's prostate, whether it's colon, that cell migrates to a different organ system. Okay. So if you have a breast cell that's causing a tumor in your brain, you don't have brain cancer. You have a metastatic cancer to the brain. Does that make sense? Okay. Angiogenesis. This is abnormal cells release enzymes to generate blood vessels to supply oxygen and nutrients to the cells, contributing to growth. This is one of the scariest things about cancer. And they talk about this like in a lot of TV shows, and you'll also hear about this, like if you've ever heard the phrase, the tumor was so vascular. Okay. That means that is angiogenesis. That is the tumor has created its own blood supply. Okay. It's vascular. It has its own blood supply. Cancerous cells rob the host cells of energy and nutrients and block normal lymph. This leads to the loss of normal cellular function. So when our cells require energy, that comes from the mitochondria in the production of ATP, cellular energy. And in order for us to have that cellular energy, we need oxygen, we need glucose, we need proteins. Okay. So if the cancer cells are dividing at a rapid pace, they're not following any direction like the other cells. They must require more energy, which is going to deplete the host, the human, of their energy. You ever think about why people with cancer have weight loss that is unexplained? It's because their cellular energy is so high that they're using energy faster than they can consume it. Okay. Causes of cancer are not clearly understood, most of them. Some of them we have found clear causes. I mean, obviously, we know that smoking cigarettes is going to put you at a higher risk for lung cancer, right? We have figured out that if you have unmedicated GERD, gastroesophageal reflux disease, and you constantly have acid reflux in the esophagus causing esophagitis, that constant breakdown of the esophageal cells puts you at a higher risk for esophageal cancer. because you're constantly regenerating the cells. Okay. So yes, there are things that we have linked to causes of cancer. And then we just have things that it just happens. It's just a cell mutation that just happens. Genetic predisposition. This is your BRCA1 and 2, right? I talked about this last week, maybe, or the week before. Did I talk about it? When I talked about when I had my breast lift, with all of my mom's history, I was ready to cut them off. I literally said to the surgeon, cut them off. And if I would have been BRCA1 or 2 positive, I would have. I absolutely would have had a prophylactic mastectomy. But neither my mom or I had the BRCA1 or 2 gene. So genetic predisposition is huge. Viral infections, because viral infections invade the host cell. And whenever you change something that's occurring within the cell, that's how cancer happens. Okay. So a bad viral infection can trigger autoimmune diseases, can trigger cancer, trigger a lot of stuff. Constant irritation and cell turnover, just like I just said about the esophagitis. Stress, lifestyle factors like smoking, diet, environmental factors like before OSHA, we had a lot of men in factories because women weren't allowed to work at factories back then. So we don't see it a lot in women right now. But our elderly population of men, we're seeing a lot of pulmonary fibrosis. We're seeing that mesothelioma. You see the commercials. If you've been diagnosed with mesothelioma and you worked in blah, blah, blah industry, right? Because those environmental factors that they were subjected to caused their cancer. And before OSHA regulations, they were not protecting themselves. Asbestos. I mean, people were literally taking down asbestos without any PPE. And now you need a full hazmat suit with a respirator to take down asbestos because it's so dangerous. And this says most likely a mosaic of factors, which means it's probably more than one that causes these things to happen. So we have solid tumors, like actual structural tumors, like carcinomas or sarcomas, and hematological malignancies, like leukemias that affect the white blood cells, lymphomas that affect the B cells, T cells, any of the lymph cells. This is a picture about how cells can change. So you see the way that the normal cells are clumped together, they're all the same size, they all have the same type of nucleus. Then your precancerous cells, some of them are shaped differently, some of them are weird. The tissue looks a little bit different, the color is off. And then the cancer cells it's just a mass of abnormal growth. Anti-neoplastic agents include alkylating agents. If you think about like alkaline versus acidosis, so alkaline is like a base, a very neutral thing. Anti-metabolites, it's going to affect the metabolism. Anti-neoplastic, neo meaning new, neoplastic just meaning tumor, anti-tumor. Mitotic inhibitors like mitosis, so stopping the growth or reproduction. Cancer cell specific agents, I think these are getting more popular with gene therapy. And then anti-neoplastic agents that cannot be classified. Excuse me. So which term is used to describe the process that occurs when cells lose their cellular differentiation and organization? I think it was the very first word, anaplasia. Yes. It is the loss of cellular differentiation and organization. So alkylating agents, these are the most useful in treatment of slow growing tumors. We have very slow cancers. We have very aggressive cancers. So it really just depends on the type of cell. Contraindications are going to include pregnancy and lactation, bone marrow suppression, suppressed renal or hepatic function. Because it's always going to be the liver or the kidneys, right? Somebody has to metabolize these drugs. And it's always either going to be both the liver and kidneys or one or the other. Okay. And it says use cautiously with other drugs that cause hepatic or renal toxicity. Alkylating agents are contraindicated during pregnancy due to their potential or severe effects of the fetus or neonate. Bone marrow suppression is going to be huge with anti-neoplastic agents. So your hematological effects include bone marrow suppression, and that includes leukopenia, which is low white blood cells, thrombocytopenia, is low platelets, anemia, low red blood cells, and pancytopenia, pan meaning many, so a decrease in all hematological cells. These drugs also cause alopecia, so the loss of hair. All drugs, this is on page 224, all drugs that cause cell death can cause a potentially toxic increase in uric acid levels. Allopurinol, which is a drug for gout, but helps relieve uric acid, has been used to help alleviate this problem. Cisplatin is belongs to this classification, and it says cisplatin with aminoglycosides may increase renal toxicity. This is under the drug-to-drug interaction on page 224. With furosemide use, it can cause hearing loss. So we're already at a risk for ototoxicity with furosemide. So if you combine cisplatin with furosemide, you're putting them at more risk. The nursing considerations for patients receiving alkylating agents, there's a lot of interventions with rationales. Our patients with cancer need a lot of support. We need to make sure that they're not becoming malnourished. Altered body image is really big for these patients because we're talking alopecia, differences in the way that their skin looks and feels, impaired fertility for men and women. Acute or chronic anxiety or fear related to their diagnosis and treatment. Why are head coverings important? Is it all about the way that they look? No.
Protect your scalp. Like this.
Okay, protection from the sun. What else? Why do we put hats on babies when they're born? Because that's where they lose their heat. So we're walking around with a big old bald head. And I can say that because my mother had a big old bald head. Okay. They already have a hard time with temperature regulation. So most people that have alopecia related to their cancer treatment will choose to cover their head because they're cold. They're already cold. Okay. Using barrier contraceptives or other types of contraceptives is very important because not many anti-neoplastic agents are capable of use during pregnancy. Believe it or not, you can get pregnant during these treatments. And that would be bad for your baby. This is just looking at the cell cycle and that anti-metabolites are going to work where they inhibit the DNA synthesis. Mitosis inhibitors are going to prevent mitosis, so prevent replication. Anti-metabolites are used for various leukemias and some GI and basal cell cancers. Basal cell cancers are usually more of a skin cancer. Where is that? Hydroxyurea falls under this category. And it is a drug that can be used for the treatment of sickle cell anemia. And it can reduce sickle cell crisis and the need for blood transfusions.
So that one can be used for certain cell of blood cancer.
Methotrexate is also on this list. Methotrexate is a very common and useful drug also for autoimmune diseases, cancers. This drug will 100% fetus deletus. Methotrexate is the drug that's given if you have a ectopic pregnancy, a pregnancy in the fallopian tube, because it will cause a spontaneous abortion.
Is that allowed?
Methotrexate, it's a very dangerous drug, not for abortion. For other, methotrexate is used commonly for autoimmune diseases, cancers, and it can be used in the situation of ectopic pregnancies.
So they don't consider ectopic pregnancies abortions.
The word abortion, the medical word abortion, is actually the term for a spontaneous miscarriage. If you ever read the word spontaneous abortion or abortion in medical terminology, they may not be referring to termination of a pregnancy by choice. So
Tread lightly.
So it's a lot of times a spontaneous miscarriage is referred to as an abortion, but it's not by choice. You know what I mean? There's a
Abortion
difference.
is the expelling of.
Yeah.
However.
Um,
Jess, I have a question about the methotrexate. Does
yeah.
it like weaken your immune system or anything?
Yes, ma'am. Very much
Okay.
so. That's why it's used for autoimmune disorders because it helps. Doesn't really help. It decreases the immune response also. Stevie, do you also take methotrexate, or have you?
No, the first line of defense that they use now is like stuff like Plaquenil. They don't just jump into methotrexate anymore. It also depends on the level of how severe your case is. So mine isn't like super, super severe,
Yeah,
but they didn't
methotrexate
take,
is a heavy hitter.
yeah, they don't
It's a
just
very
jump
serious
into
drug.
methotrexate anymore.
They used to. So methotrexate can also be used for symptomatic control of severe psoriasis, rheumatoid arthritis, juvenile rheumatoid arthritis, as well as leukemia, breast cancer, and different types of carcinomas. So my biggest point is use contraceptives and barrier contraceptives, because if you get pregnant and you take these drugs, your fetus will not survive. Anti-neoplastic agents. Hold on. I would definitely look at the nursing considerations for patients receiving anti-metabolites on page 230 and 231. This is going to include everything about methotrexate and hydroxyurea, and all of the important things. So, for example, ensure that the patient is well hydrated to decrease the risk of renal toxicity. Anticipate reduced dosing if renal impairment is present. Protect the patient from exposure to infections, because bone marrow suppression will limit immune inflammatory responses. Plan for appropriate rest periods, because fatigue and weakness are common effects of the drugs. Avoid situations that might lead to infection, including crowded places, sick people, and working in soil. Use safety measures such as not driving or using dangerous equipment due to possible dizziness, headache, and drowsiness. I feel like that says that like on everything. Use barrier contraceptives to reduce the risk of pregnancy during treatment or therapy. Monitor for adverse effects, bone marrow suppression, GI toxicity, neurotoxicity, alopecia, renal or hepatic dysfunction. I feel like if you read and study each one of these nursing consideration boxes, you are going to be very well off, because they literally combine everything into that one place. Now, of course, there's going to be little outliers that I've said like, oh, this is important, blah, blah, blah. But I really like how they combine all of the information. Instead of looking at 4 pages on one classification, you're looking at 1 page, okay, with the whole nursing process. So I really want you to look at these.
For all of the drugs you've been over.
Yes, everything. Because I feel like I've said it like so many times.
Yeah.
And I just feel like they're so good. Anti-neoplastics. It's basically the same thing. Bone marrow suppression, thrombocytopenia, If we're low on platelets, what are we at risk for? Bleeding. What are we not going to be using? Razors. Okay. Don't use a soft bristled toothbrush. Use an electric razor. Okay. Don't go walking around outside barefoot. Okay. What is the irritation of the mouth caused by these drugs called? Stomatitis is a good one. And no, not thrush. Well, I mean, thrush is it's a side effect from the bone marrow suppression. Huh? Gingivitis. Gingivitis. Xerostomia.
Did we go over that yet?
Uh-huh.
Yeah.
Okay.
Stomatitis, which is inflammation of the mouth. Xerostomia. So it's very common for chemo drugs or any of these drugs to cause irritation of the mouth and cause sores in the mouth. What do you think is going to happen if you have sores in your mouth?
Not want to eat.
I don't want to eat. I want to eat. What do I need for these patients? Nutrition. They have to have nutrition. Their cells are using their metabolic energy faster than they can possibly consume it, leading to your unexplained weight loss. Then you add chemotherapy into it with nausea, vomiting, diarrhea, and everything else, horrible fatigue. You got sores in your mouth hurts, you can't drink, you can't eat. What do you think's killing you faster? The cancer or everything else that's happening to you?
Everything else.
Okay. I have a little post-it note right here about doxorubicin. Page 233. Doxorubicin is a anti-neoplastic under contraindications and precautions. Care is necessary when administering these agents to patients with the following conditions. Bone marrow suppression, which is often the index for redosing and dosing levels. Suppressed renal or hepatic function, which might interfere with the metabolism or excretion of the drug. GI ulcerations or ulcerative diseases. Pulmonary problems. Oh, here we go. Cardiac problems with doxorubicin. But there's more to that. There's like a let me see it. Let me find it. I believe there is only a certain amount of this drug that you can have in a lifetime before it like kills your heart. It leads to cardiotoxicity. Where is it? I'm gonna find it. Cardiac toxicity, complete but reversible alopecia. Doxorubicin has been known to cause cardiotoxicity in addition to non-harmful red coloration of the urine and sweat. I swear there's something about a lifetime amount. Will you look that up?
What page were you just looking at for that?
233. It starts on 233.
Because I clicked on a box that somewhere else.
Because I swear it's something about a lifetime.
It says In adverse effects, on 233, it says dexrazoxane is approved for reducing cardiomyopathy associated with doxorubicin in patients being treated with breast cancer. So
Maybe I'm just thinking
Clicked on-
about something else.
yeah, I clicked on that box and it took me somewhere else, but that didn't give me.
Yeah, maybe I'm thinking about something else. Okay, I'm not gonna stay on it. Okay. I really thought there was something like that. Okay, mitotic inhibitors. These are drugs that interfere with the ability of the cell to divide, so it stops mitosis. Again, your adverse effects are going to be bone marrow suppression, thrombocytopenia, anemia, pancytopenia, GI effects. They're toxic to the liver. They're toxic to the kidneys. They can cause prolonged QT interval prolonged QT interval.
It just says it carries a risk of cardiotoxicity related to the amount of the drug a person receives over their lifetime, but it doesn't give
It doesn't give a lifetime dose. Okay. Hormone and hormone modulators. These drugs, these can cause a lot of issues. If your tumor is hormone responsive, that means that the hormones in your body are feeding the cancer. So especially with like estrogen related tumors, they're fed by estrogen. Guess what? We can't really function very well without estrogen because that's just what happens in a biological woman, a female, okay? Just like men aren't going to function super great without testosterone, okay? So the adverse effects to your hormone and hormone modulators are going to mimic the way that we use those hormones. So adverse effects, which is on page 241, adverse effects frequently encountered with the use of these drugs include those seen when estrogen is blocked or inhibited. Menopause-associated effects include hot flashes, vaginal spotting, vaginal dryness, moodiness, depression. Other effects include bone marrow suppression, GI toxicity, hepatic dysfunction. Hypercalcemia, this is important too. Hypercalcemia is also encountered as the calcium is pulled out of the bones. Without estrogen activity to promote calcium deposition. This causes weak bones and osteoporosis. Okay. My mother-in-law was on one of these drugs for 5 years after her breast cancer diagnosis, and she blames it for everything. It ruined her entire life. 5 years on that drug. That's why my knees hurt so bad. Probably, Mary. Probably. Okay. Drug to drug interactions. If hormones and hormone modulators are taken with oral anticoagulants, there is often an increased risk of bleeding. And it might increase your serum lipid levels, so your triglycerides. So these adverse effects are going to be very, very much obviously they're hormone modulators, hormone related, menopause, gynecomastia, anything that is inhibiting estrogen or inhibiting testosterone, okay? So when we're looking at the nursing considerations for these drugs, which starts on 241 and goes into 242, monitor bone density and blood calcium levels due to the decreased bone density and hypercalcemia. Blood pressure, pulse, perfusion to evaluate the status of the cardiovascular system. Assess for hot flashes, decreased libido, gynecomastia, erectile dysfunction, irregular menstruation. Encourage calcium and vitamin D intake. Provide comfort measures such as hygiene measures, temperature control, stress reduction to help the patient cope with changes in reproductive health, like decreased libido or erectile dysfunction or menopausal signs and symptoms. You're caring for a patient with a Wilms tumor. By the way, a Wilms tumor is attached to the kidney. I saw one once. It was crazy. When I worked in the OR, we had to take one out, and it was huge. Who is receiving doxorubicin? What is an adverse effect of this drug? I just said this.
B.
B. Is it B? It is B. Red urine. Doxorubicin includes cardiac toxicity, complete but reversible alopecia, nausea, vomiting, mucositis, which is inflammation of the mucous membranes, red urine, myelo meaning bone marrow. So whenever you see that word, myelo, myelosuppression means bone marrow suppression. Okay, I promise you're probably going to see it.
You said the Wilms tumor was on the kid.
Yeah.
And MYELO, bone marrow.
MYELO suppression. That means bone marrow suppression. What'd you say?
Yeah, I spelled that all the way wrong.
So cancer cell specific agents, the goal of current research is finding cancer cell specific drugs. This sounds like a really great idea. I hope that they continue being successful with this. Who knows, because pharmaceutical industry runs the world and they make money off of us being sick. So diabetes will never be cured. Hypertension will never be cured. Cancer will never be cured because there's too much money in it. Let's just be honest.
They're greedy.
So greedy. Okay.
If there was a cure, would they have to disclose it to America?
No. There was a scientist that came out not that long ago that said there's been a cure for cancer and they just won't.
I feel like those people that I feel like if we all in this classroom, we all got sick right now. I just feel like it's something that can reverse it.
Yeah,
We
probably.
only been here, so that's how I feel about the world. Like we all living in this world, and it's things that make us sick.
What does Magic Johnson have?
AIDS.
AIDS.
Now.
Dude,
Pretty much cured.
Thinking every time to be.
dude is so healthy. He's probably healthier than me.
You can't pay me to say that.
I'm telling you, that dude got something.
Money cured. You didn't say I got money cured.
This was another drug that we tried to treat COVID with that didn't work. And it acts on specific enzymes for protein building. So we were trying to like kill the virus with this drug and it didn't work. A lot of things didn't work. Here's St. John's wort again. St. John's wort is everywhere. That's what I'm saying. Like these things that are contraindicated in everything, like sorry, Candace, grapefruit juice, just stop making it. St. John's wort, stop giving it to people. It's obviously not a great thing. Like
If it interacts with everything, it can't be that safe for your body.
if it interacts with everything, like is it yeah, I don't know. Anyways. Miscellaneous anti-neoplastics 14.7. I don't care about any of those.
I just want to know who called it St. John's wort because I expected something like nasty, and it's like this really pretty yellow flower. It's a beautiful flower. Of course it is. It's a beautiful flower. I expected it to just be like nasty because it reminds me of like a toad or something. Like
a toad.
Something gross. Oh, it's gorgeous.
All right, so here is when we have our introduction to the immune system and inflammation. We're going to kind of go through the inflammatory response, the immune response. What does what? So we have natural body defenses. We have barrier defenses, which is basically our skin, the hair in our nose, the hair in our ears. Cellular defenses, our inflammatory response, and immune response. And you can also refer to these as the inflammatory cascade or the immune cascade, because what happens is something triggers it and then it cascades down into many, many, many things. So our barrier defenses is our skin. It's our largest organ. It's the first line of defense. Mucous membranes. So any mucous membrane, your mouth, your nose, your eyes, the vagina, they're all protect from invading organisms. Gastric acid, acid destroys most things, and it is a huge way of protecting us. Major histocompatibility complex. This is the way that our body says, I see you, breast cell, and I know what you are, or I see you, breast cell, and I don't know you. So it's the way of self-recognizing versus you're foreign and I don't like you. Autoimmune diseases occur when this complex gets screwed up. So cellular defense, we have our mononuclear phagocyte system. Your phagocytes are those big cells that eat bacteria. We have lymphocytes, which is your T cells, your B cells, your natural killer cells. This is your immune system. Myelocytes, this is your bone marrow. These are the cells that come from your bone marrow. Your neutrophils, basophils, eosinophils, monocytes, macrophages. So this is just looking at the types of white blood cells. We have our natural killer cells, which are very good at killing pathogens. Our B cells make antibodies. And we have 3 different types of T cells. Lymphoid tissue, this includes the lymph nodes, the spleen, the thymus, bone marrow. So your lymphoid tissue, it either makes lymph cells or it stores them. Okay. The inflammatory response or the inflammatory cascade, it all starts with an injury. So it is a reaction to something that has invaded the body or has injured the body, is causing inflammation in some way. The injury causes the activation of the Hagman factor. And then the Hagman factor activates the Kinnin system. The clotting cascade. And the plasminogen system. This is all on page 260. So the Kinnin system has its own cascade. So the bradykinin causes local vasodilation. So it brings blood to the injury. Prostaglandins either help or block inflammation. If you think about, or if you have recently written the mechanism of action for Tylenol or aspirin or NSAIDs, they talk about inhibition of prostaglandins, inhibiting COX-1 and COX-2. When we talk about COX, we're talking about the cyclooxygenase because it's part of the inflammatory response. Prostaglandins is part of the pain and inflammatory response, which is why your pain medications and your anti-inflammatory medications are working on those specifically. Leukotrienes cause vasodilation. Thromboxanes cause local vasoconstriction and they help platelet aggregation. So this picture is on page 261. It's basically just giving you the exact inflammatory response and the immune response. So on the left side is it all starts with the tissue injury. On the left side, you have the Hagman factor, which goes into the oh my god, the blah blah blah. What's it called? Kinnin. Yeah, the Kinnin system. And goes through the prostaglandins and the leukotrienes and all the things. On the right side is the immune response, where we have the release of histamine. We have vasodilation, increased blood flow, edema, And all of these things lead to pain. All of these things cause pain. A barrier defense that the body has is gastric acid. True or false? Tis true. So then to our histamine response. If you look at the picture, it shows you that the release of histamine causes vasodilation. It causes an increase in blood flow, which is what causes your skin to get hot, right? When we talk about signs of infection, we talk about the site being red, hot, painful. So the vasodilation that increases blood flow causes heat, also causes redness. It increases the capillary permeability. That means fluid, plasma, rushes to the site, which causes swelling or edema. Increased capillary permeability. And all of these things are leading to pain. The thing with inflammation is that it's a great, it has a very, very important job, but sometimes inflammation can actually cause more injury than the original injury. Okay. So it's important that we don't let inflammation just go crazy. That if it is an extreme, it has to be controlled because it will cause more damage to the surrounding tissue. So there's a difference between acute inflammation and chronic inflammation. Acute inflammation, you sprained your ankle and your ankle blew up like a balloon. Okay. It can last minutes to days to maybe even a couple weeks, to be honest. I fell on my knee December 19th and it still hurts. To this day, it still hurts and it pisses me off because I am a runner and I cannot run. I have not been able to run in almost 2 months. And then chronic inflammation can last up to years. This is the inflammation that can be very harmful and change the way that your body functions and moves. Of chronic inflammation? Celiac. So if you don't know you have celiac and you're just like eating whatever, your intestines are chronically inflamed.
So yeah, people can't eat
Gluten, yeah.
It's chronic more so like inside the body. It's more so outside the body.
Not necessarily, but she said is acute more like outside the body and chronic more inside, not necessarily. Because acute inflammation can happen anywhere.
Right.
I feel like chronic inflammation would more be like inside.
But just not the acute.
Yeah. Yeah, acute can be anywhere. Yeah. That's not a bad question. We already well, we didn't talk about the words. So calor is another word for heat. You're not going to see this word very often. Most likely you're going to just see the word hot or, the area was hot to the touch, warm to the touch. But it's good to know that calor is a medical term for heat. Tumor can mean swelling. So if you see the word tumor, we don't see it often. Most of the time you're going to see edema. I don't know if I've ever actually seen the word tumor in regards to swelling in any type of like medical charting. Rubius. That just makes me think of Hagrid. Just think of red R, Rubius, like a ruby, red. And then dolor for pain. Again, this is not a word that you're going to see often, if at all, but it is a word for pain.
Why? Can I ask a question? You
Yeah.
know why there's like color and dolor? Those are like two Spanish.
Are they Spanish? Or do they mean that in Spanish? Yeah. Oh, I don't know.
That's what I was reading. I was like, I had to second guess myself.
Well, so a lot of med term is Latin, and a lot of the languages are based off of Latin.
Yes, that makes sense.
So, yeah, that's interesting. I didn't know that.
Yeah.
I failed Spanish. So, just saying.
Took 5 years.
I withdrew from Spanish my sophomore year because I was failing, and then got a different teacher and got a B. I have no idea how.
Very well.
No idea. But I had to have it to graduate. I can count to 10. What factor stimulates macrophages and neutrophils to be very aggressive? So macrophages is I'm going to eat all the bacteria. The neutrophils are a type of white blood cell. So cellular defenses makes sense. Histocompatibility, that's the ability to recognize our own cells versus foreign cells. Our barrier defenses, it wouldn't be that because that's our skin, our mucous membranes, our gastric acid. And then chemotaxis is chemical, could be enzymes or whatever. So I don't think it's either B or C. What do you think?
I think it's
She thinks it's A.
because I don't remember.
I also don't remember the definition of D.
I would do both.
If I were taking a test and this is what I would go A because that looks most familiar and I don't remember D.
Chemotaxis is the property of drawing neutrophils to an area.
Oh, well then maybe it's D.
It might be D.
It might be a winner.
The answer is D.
See what happens when you don't know your terms?
Definitely would have got.
I with A because it looks familiar.
I mean, okay, so the immune response. This is more specific invasion can stimulate a more specific response through the immune system. So lymphocytes produced in the bone marrow can develop into T or B cells. Other identified lymphocytes include, we talked about the natural killer cells, lymphokine activated killer cells. We don't need to know that. These cells are aggressive against neoplastic or cancer cells and promote rapid cellular death. We love that. Natural killer cells are intense. They're aggressive. Are effector or cytotoxic T cells, they're aggressive against foreign cells. The helper T cells, they do exactly that. They help the other lymphocytes. And then the suppressor T cells, they are like, whoa, guys, relax. This is a war, not, it's a battle in the war. We have to conserve energy. You got to chill. So the suppressor T cells, they try to take control of the situation. The role of the B cell, the major role of the B cell is to produce antibodies. Okay. They can identify specific antigens, which is your foreign guys, the bad guys. And they can produce antibodies. So antibody formation, there are multiple antibodies, and some, if not all of these, can be given as treatment. Specifically, IgG and IgE are both more common than the rest. This can be helpful with people that have autoimmune disorders that are specifically missing the type of antibody. Okay. Interferons prevent viral replication. This is our body's way of trying to fight off viruses. The thymus, remember we said that our lymphoid tissue either produces or houses our T cells, B cells. So our thymus releases hormones that aid in the maturation of T cells, and they also give them a home to live in. Tumor necrosis factor, TNF, this is a chemical released by macrophages. It inhibits tumor growth. So the whole point is that the immune and the inflammatory system work together. They work together to protect the body, maintain homeostasis. And the way that they do that is the Hagman factor and histamine facilitate the action of the neutrophils. The helper T cells stimulate the B cells and the effector T cells. They just help each other along the way. The word neoplasm, neoplasms occur when mutant cells escape the normal surveillance of the immune system and begin to grow and multiply, which is cancer. Whenever you see the word neoplasm, this is a new growth. It's a bad growth. It's most likely cancerous. Viral invasion of cells. This is when viruses are parasites that can survive only by invading a host cell. And we already know that when we talked about the antivirals. We know that autoimmune diseases occur when the body responds to its self cells like they're foreign. And then transplant rejection is when the body attacks a transplanted organ, which is why compliance of anti-rejection medications is extremely important.
And blood work. Because they look specifically.
Don't care about that.
Chapter was that? That was 15. We're on 16 now.
Okay, so we already went through the entire inflammatory response. I don't think we need to do it again. We know that steroids block inflammation. They also suppress the immune system. So corticosteroids are used systemically to block inflammation, immune response, and if they're used topically, they can produce a local anti-inflammatory effect. Antihistamines, like my Zyrtec that I take every morning, blocks the action of histamine. It helps with my allergies. Salicylates. Aspirin. Salicylates are aspirin. There are other salicylates, but your most common is aspirin. Aspirin has 4 different mechanisms of action. It blocks the inflammatory response. It is the original NSAID. So it's an anti-inflammatory, antipyretic, lowers your fever, analgesic, blocks the pain, and it's an antiplatelet aggregator. So antiplatelet aggregator. Antiplatelet aggregator. This is your list of salicylates. I have only ever seen aspirin. I've never seen any of these other medications in the hospital, but that doesn't mean they're not used. It just means that they're not common. Talked about prostaglandins cause pain. So this inhibits the synthesis of prostaglandins, which treats the pain. It works really, really quickly. It obviously has its own bleeding risks. And you want to stop taking aspirin at least 1 week before a scheduled surgery or invasive procedure. Salicylate toxicity is something I want you to look at. So on page 274 under adverse effects, it talks about salicylism versus salicylate toxicity. So salicylism can occur with high levels of aspirin. It causes dizziness, ringing in the ears, difficulty hearing, nausea, vomiting, diarrhea. Acute salicylate toxicity may occur at doses of 20 to 25 grams in adults or 4 grams in children. The signs of salicylate toxicity include hyperpenia, tachypnea, hemorrhage, dehydration, excitement, confusion. This is all on page 274. Pulmonary edema, convulsions, tetany, metabolic acidosis, electrolyte imbalances, fever, coma, cardiovascular, renal, and respiratory collapse. What did they make chewable? Aspirin. And they have nice flavors. So what happens when your kid gets a hold of a bottle of aspirin that's chewable and tastes like oranges? Great. They eat them all and then die. Okay? So, in order for them not to die, what is the antidote for aspirin or salicylate toxicity? So it's a little bit of a trick question because the first line of defense is activated charcoal, which is also referred to as a chelating agent. CHELATING. 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 Chelating, which means it binds. The activated charcoal binds, huh? CHELATING. Chelating. It binds. So activated charcoal is your first line of defense. We can also use sodium bicarbonate. But the reason that salicylate toxicity is so dangerous, especially in children, is that there is no direct antidote. We can try to alleviate it with the activated charcoal and the bicarb, but there's no actual true antidote. Okay. So this says monitor for severe reactions to avoid problems and provide emergency procedures, which include gastric lavage, which means they put fluid in just to take it out. So try to kind of like clean your stomach out, pump your stomach per se, vomiting, administration of charcoal if they occur, arrange for supportive care and comfort measures to decrease the body temperature or to alleviate inflammation. Ensure the patient is well hydrated during therapy to decrease the risk of toxicity. And I'm pretty sure I put something on Brightspace about salicylism. Also, a little key points box on page 275 that talks about salicylism, ringing in the ears, acidosis, nausea, vomiting, diarrhea, confusion. Lassitude. I don't know what lassitude is. I have to look that up. Lassitude is a state of physical or mental weariness, exhaustion, or a lack of energy and interest, often stemming from strain or illness. It is not relieved by rest, which differs from normal tiredness by its intensity and persistence. So it is a profound exhaustion, physically and mentally.
There is something for poisoning, which is very tiny. It doesn't get.
Oh, can you download it?
Yeah, I've not been able to figure out how to print any of those. They get so blurry.
I know, they suck. That's why I replaced most of them. I'll replace it. I'll replace it.
Thank you.
We got 20 minutes. A person who does not respond to one salicylate may respond to a different one. I don't know. True or false? It is true. NSAIDs. So NSAIDs provide strong anti-inflammatory and analgesic effects. They are one of the most commonly used drugs, linked to increased risk of cardiovascular events and death and increased bleeding in the GI tract. If you don't know, I hope you know that NSAIDs have a huge risk for increased bleeding. They block COX-1 and COX-2. Remember, I was just talking about that. Contraindicated in the Presence of allergy to sulfonamides, cardiovascular dysfunction or hypertension, peptic ulcers or GI bleeding. If you already have a GI bleed or ulcer, you should not take NSAIDs. No, no, no. Renal or hepatic dysfunction. Biggest, absolute, largest adverse effect of NSAIDs is bleeding. There are multiple drug-to-drug interactions. It can decrease the effect of loop diuretics, decrease antihypertensives of beta blockers, can increase lithium toxicity, increase bleeding with anticoagulants, alcohol, or glucocorticoids. These are your NSAIDs. Your most common is going to be your ibuprofen and naproxen. On the other side, the most common is your indomethacin and I always say this word wrong. Ketorolac.
I see a lot of diclofenac in like Voltaren gel stuff. In long-term care, there's a lot. If your knee hurts, you're getting.
Oh, I never read the backs of that box. What is it? Voltaren?
Voltaren.
Voltaren has the other.
It's the diclofenac.
Diclofenac.
They pass that up in the nursing homes.
The the ketorolac, that's Toradol. Toradol is a hell of a drug. It is beautiful. I had gastritis one time. Oh my God, it was so bad. It was horrible. My stomach hurt so bad. And they gave me Toradol and I went from being in and this was before I had a baby. So the most pain I had ever felt at that time in my life to like no pain at all. And I was like, this is the most miraculous thing that's ever happened to me.
Yeah.
And there's no euphoria. It's not an opiate, but they have to be careful with Toradol because it'll kill your kidneys. Non-steroidal anti-inflammatory. First of all, Tylenol is not in NSAID in any way, shape, or form. That's why it's a related agent. It is not an NSAID. Okay. What is the most amount of Tylenol you should have in a day?
Why is 4,000 a day popping in my head?
Because that is correct. 4,000 milligrams or 4 grams is the most amount of Tylenol, acetaminophen that you should be taking in a 24-hour period. It's lower than that if you have renal disease. Okay. Or 4,000 milligrams or 4 grams is the most acetaminophen that should ever be taken in one day. That is the maximum dosage. It is used to treat pain and fever. It is one of the only pain medications that we can take while pregnant. Apparently now it causes the TISM, which was ruled out, by the way. Tylenol does not cause the TISM. You want to be careful with renal dysfunction, hepatotoxicity. Hepatotoxicity usually happens with chronic use. You do not want to drink alcohol and take Tylenol together. It's not good for the liver. Drink alcohol? Probably not. But there are drugs that are worse with alcohol. When are NSAIDs contraindicated? B. Salicylates, because salicylates are NSAIDs, specifically aspirin. Anti-arthritis agents. These prevent and suppress arthritis in selected patients with rheumatoid arthritis. This is where your methotrexate and your hydroxychloroquine come in. Okay. What? Hydroxychloroquine or Plaquenil? So the gold salt, it's literally called gold salts. Gold compound. Some patients with rheumatic inflammatory conditions do not respond to the usual anti-inflammatory therapies, and their conditions get worse. And some of these patients respond to treatment with gold salts, also known as chrysotherapy, in which gold is taken up by macrophages, which then inhibit phagocytosis. It can be very toxic and is reserved for patients who are unresponsive to conventional therapy. So it is not common. You do not want to use gold salts in severe diabetes, CHF, severe debilitation, renal or hepatic impairment. It's not good for the ticker. No, it is not. And any history of toxic levels of heavy metals, because heavy metals accumulate in our bodies. DMARDs. DMARDs include hydroxychloroquine and methotrexate. So DMARDs stands for disease-modifying anti-rheumatic drugs. And they have very serious side effects. Tumor necrosis factor blockers, that is a drug classification. These are your biologics. If you've seen commercials for Humira, Remicade, Enbrel, that is this classification of drugs. It's given sub-Q, and it usually lasts a while. Like whether it's a week or a month, and then that you either have like weekly injections or monthly, bi-weekly, depending on the drug. And the point of these drugs is to decrease the inflammatory response in autoimmune disorders. So these can be used for Crohn's disease, rheumatoid arthritis. I don't know if Cosentyx is on this. I don't know if that is falling within another Cosentix is another biologic. So these cannot be used in anyone with an acute infection, cancer, sepsis, tuberculosis, hepatitis, bone marrow suppression, demyelinating disorders like MS. Why? Because it's already, these drugs, first of all, if you have any of these, your immune system's shit. So if you're going to put a biologic on top of this, you are going to get very ill. Very, very ill. Because there is a big box warning about the risk of serious to fatal infections and the development of lymphomas and other cancers. The use of biologics is very much like a last resort, Hail Mary situation. Okay. It can be very destructive to the host. But some people have such significant daily symptoms that they would basically do anything and take these risks to not live with the symptoms that they're living with. Whenever we have anything injected, we're always thinking about site reactions, pain with injection, risk of infection at the injection site, rotating injection sites. Anti-gout and hyperuricemia. This is your allopurinol and colchicine. Whoop, go back. So this is on page 287. Colchicine is for acute gout. And allopurinol is more chronic. It lowers the blood levels of uric acid. So it's more for chronic use. Colchicine is for acute gout attacks. All right, we got 5 minutes. I really wanted to get through 17 and 18.
How many more chapters do we have Monday? I mean, today.
Tuesday we have GI 56 through 60, I think. Yeah.
Sure.
I know. It's a lot.
I ain't making it out.
Oh, unfortunately, yes.
Is our lecture before our ATI thing? Isn't that on Tuesday too?
A girl. I don't know. What I can do, and I mean, I guess this is going to be mostly up to you guys. But you have to, because listen, the last time I told you to go over a chapter, most of you didn't. Okay? Most of you did not review chapter 37 like I done told you to. And there were how many questions on thyroid? A lot.
Well, that's when the came. Can't complain if you know you didn't review it.
So I didn't have complaints. It's not that I had complaints. I'm just saying I it's very important to me. Your success is very important to me. So if I offer to pre-record a lecture and then do our review on Tuesday instead of Monday night, then it's on you because I'm not teaching Tuesday. If you don't review that content, I can't help you, because if I pre-record a lecture and send it to you, I will not be teaching it on Tuesday. It will be a review. So that's, you guys tell me what you want to do. We either stick with the original plan of the exam review and then the review Monday night, Tuesday having lecture, or I pre-record lecture, send it out to you, and then we have a review day on Tuesday before your ATI.
Personally, I would rather.
I agree.
I want a vote. So everybody put
So
their.
then we wouldn't have the 3 p.m. and the 7.
Correct. We would only have the 3 p.m. So put your vote in the chat. You in front of me, raise your hand for pre-record. Everybody's saying pre-record.
Because it's different.
Yeah. Monday at 3 is the exam review.
I did like these things going up though.
No. It was supposed to be going over the exams.
What goes on
That's what I
Monday
just
at
said, the
3?
exam review. Monday at 3 o'clock is the
sorry.
exam review.
Sorry, I thought
exam
it
review,
sounded
the
like
final
review
exam
for the
review.
next exam.
No, ma'am. Test integrity. I do not record my exam reviews. And if I ever find out that you have recorded any of them, not you specifically, anyone,
But you
I
said
will
you
have you
don't
removed
record
from this
those,
program
right?
before you can say remove. I wasn't coming at you, girl. I wasn't coming at you. I'm just making it very clear.
Okay, I was only wondering because I work from 4 a.m. to 8
Do you have
p.m.
clinical tomorrow?
Yeah. I work from 4 a.m. to 8 p.m. every single Monday. So I was just wondering. But
I was hoping you were going to
okay.
say no, because then I could meet with you tomorrow.
Absolutely. If my clinical instructor shows up, sure.
Question: if he doesn't show up again, like how long before we so the last time we were all like sitting there, like how long before we can leave? Like
Dude,
because the last time.
I'm gonna be so mad. This is hold
But
on.
you want to know? I heard he was 45 minutes late.
Wait. This is a conversation that we are going to have after we stop this recording and everybody else is gone, because this is a very
we sat there for over
specific
an hour.
conversation with only your clinical group. Okay. Okay. Does anybody have any questions about anything? Everybody knows exactly where they're supposed to be and what we are doing next week.
Okay, I
Yes?
think I want to be clarified. I want to clarify. So you record the videos of the remaining class. I mean, the remaining lectures we're supposed to take before the exam, right?
Okay, Stella, I need you to start over, girl, because I didn't realize you were talking to me.
Okay. So what I was asking is, you're going to pre-record everything that we're supposed to do before the next exam on Thursday?
I am
and
going
then
to pre-record chapters 17, 18, 56, 57, 58. I don't know how long it goes. I don't know if it goes to 60.
Okay.
I don't remember. But yes, I'm going to
okay,
send that
just the
to you.
remaining. Yeah. Okay, then we're going to review our exam on Monday
At 3
3
o'clock.
p.m. Okay.
And then on Tuesday, We are
Okay.
going to have our final exam review before the
Final
ATI.
exam. So what are we reviewing on Monday again? ATI?
The only thing we are reviewing on Monday is exam 1 and exam 2 as a group.
Okay. Okay.
Okay.
We're not reviewing
Okay.
ATI at all.
Okay, I think I got
I
it
don't
now.
review ATI.
The API is just the.
I saw this work on it.
Yeah. Yeah, I don't review ATI.
Right. So right
For the
that's what
Tuesday.
all of class Tuesday before it.
Do I need to take it down? I feel like I need to write this down.
You should just send an email.
Okay.
Maybe send us email.
I'm gonna send an email.
Thank you.
Does anybody have any questions before everybody goes and I can talk to my Sylvania group? And also, we can't spend a lot of time because there are some people that still need to take their math exams today. So when can we expect the pre-recorded lecture? Ethan, that's a great question. It's a wonderful question.
No,
I definitely want to have it out before. I would like to have it out before Sunday, for sure. We'll have it done tomorrow. Is the ATI 10% of our grade combined with the other? No, it's not combined. Or just this one, it's that one by itself.
Okay, can we have the pre-recorded video of the last class,
I thought
please?
those were conditions.
I don't know.
It's on there. I've already put it on there.
Okay, okay, thank you.
Yeah.
I was ready. I was gonna drink one in class.
Anybody else?
One more. I'm sorry, everybody. So after we take the ATI proctor, we'll get our score, right? Right there.
Yes.
Because it put me in overtime.
And so then before we start crying, if we do poorly, we can still have a chance to do well on the final, correct?
Yes. Yes, absolutely.
I mean, any difference isn't that big of a difference.
It's gonna be okay.
So I'm banking on the final to get me through this, not the ATI. I ain't even gonna lie to you. You said on the final there's 70 questions.
It's gonna be Chastity. You're always trying to get something out of me, and I'm telling you, girl.
Listen, because I got a call from Terry. I've been trying to tell you this for weeks, and we just haven't been lining up to talk one-on-one. So I'll just say it out loud. I don't care. I got a call from Terry. She like, girl, your GPA ain't it. All these A classes that we got left, if you don't get a B+ or higher, you're not graduating with your crew.
Mm-hmm.
I was like, Terry, we're not going to do that. And she goes, exactly. So make sure you have a B+ or higher in your classes.
Amen. I'm sure you're not
So
the
I'm just
only
trying-
one out of these 50 students that's in that boat, Miss Chastity.
Well, what's up, 50 other students that are in the boat? We need to stick together because I'm stressing here.
I didn't say everybody. Tony's looking at me like I'm crazy. I didn't say. I said there's got to be at least one other person that's in that boat. So.
All right, so it'll help both of us then. Just 70 questions, so I need now.
It's going to be around 70. Preferably maybe
Okay.
more than 70, but definitely not more than 80.
Okay. So I can figure out just in case I miss so many. Is there wiggle room? That's all. That's all.
I hear you, girl. I hear you.
Thank you.
Okay.
How do we, what percentages are the level 1, 2, and 1 and 2?
You mean like the grade percentage or the percentage you need to get?
Yes. The percentage you need to get.
Chastity, do you have those written down? Because it's in my office. Go ahead.
I have those written down.
Oh yeah, I gave
from
them
when we
Pam yesterday.
met. So for level, so from 0% to 52%, 52.6%.
Fix your face.
It's below a level 1. A level 1 is from 52.7% to 71%. A level 2 is 71.1% to 86.2%. And then a level 3 is 86.3% to 100%. I can put it in the chat too so people can see it.
Correct. That is
Thank
correct.
you.
Put it in
Yes.
and reply. Put it in the email because as soon as I end this call, nobody's gonna be able to see it anymore.
Okay, perfect. I'll send it in the email.
Okay. I'm sorry, girl. I'm sorry. It's just the easiest way to talk to everybody at once. I know you work nights.
You understand you stress me
Welcome.
out with them group damn emails, right, Miss Jessica?
Okay. Anybody else?
Miss Jessica, is there any way that after we get our pre-recorded lecture, we can also get our like things to know for the final that we could study? Specific
Yeah, I'm gonna have your
things?
key. Yeah, I'll have your key points. Yeah.
Thank you.
Nothing, bro.
Mm-hmm.
Okay. Most relaxing.
Okay. Everybody good?
Yes.
Oh.